Good morning. Thank you. It's wonderful to see all of you here today. This is the last day, and I'm so glad you still have the energy and the inspiration to be here with us. So this is the keynote, The Importance of Responsible Governance to Achieve Sustainable Global Health Outcomes. In a world where we know health outcomes remain vastly unequal, preventable diseases still claim millions of lives, as we heard from Dr. Rhonda Seeley-Thomas of PAHO, and where access to basic health care for all is still a challenge everywhere around the world. The need for effective leadership and governance has never been more important. Waging peace, fighting disease, and building hope in communities worldwide. The Carter Center has long stood at the forefront of this intersection between governance and global health in its mission to improve lives by resolving conflicts, advancing democracy, and preventing diseases. From its groundbreaking work in eradicating guinea worm disease and working to eliminate other tropical diseases, to its efforts in addressing mental health and strengthening healthcare systems in communities, the Carter Center has demonstrated how strong leadership and governance can transform public health outcomes. I shared with you on Wednesday a historical fact about Atlanta, and I have another one for you today. So the Emory University president in 1982 worked with President Jimmy Carter, to create the Carter Center. It's been recounted to me numerous times how Jim Laney, who was the president of Emory at the time, said to President Carter, "You cannot only be in planes. You still have much to offer the world." Later, he went on to say, Jimmy Carter is the only person in history for whom the presidency was a stepping stone. And now we fast forward to today, and we're privileged to have Ms. Paige Alexander, the CEO of the Carter Center, with us here. Under her leadership, the Carter Center continues to build upon President Carter's incredible legacy of humanitarian service, working tirelessly to advance health, hope, and dignity for communities worldwide. Paige has been described as a dynamic, collaborative, strategic person, adept at navigating complex global issues, tenacious, and deeply committed to global development. These are only a few things that people have said about her. I've had the privilege to collaborate with Paige and the Vice President for Global Health at Carter Center, Dr. Kasha Vijaz, for nearly 4 years, and I can wholeheartedly agree with all of those comments and sentiments. I've watched her recently oversee and coordinate the planning of events in memory of President Carter. She worked tirelessly both here in Atlanta and in Washington, D.C., and I saw her absorb and take solace in the outpouring of memories and compassion from people all around the world, from communities everywhere. And most recently, I saw her concern and compassion for her colleagues and friends at USAID while finding solutions to how to help people. We are fortunate to have Paige where she is now. Throughout her distinguished career, with over 25 years of experience spanning both government and humanitarian sectors, Paige has demonstrated an unwavering commitment to advancing human rights, democracy, and global development. Before joining the Carter Center, she served as executive director of the European Cooperative for Rural Development based in Brussels, working to improve the livelihoods of rural farmers worldwide. Her extensive experience includes Senate-confirmed senior leadership posts at USAID, where she oversaw programs in Europe, Asia, and the Middle East, bringing vital healthcare development initiatives to communities in need. At the Carter Center, she's continued President Carter's vision of advancing peace and health worldwide, leading initiatives ranging from strengthening democratic institutions to eliminating neglected tropical diseases. Under her leadership, the Carter Center has further enhanced its reputation as a trusted partner in global health governance, working alongside governments and communities to build sustainable solutions. You can read more about her illustrious career in the bio in the CUGH program. And with that, please join me in welcoming Ms. Paige Alexander. Thank you.
Yes, thanks. Good morning. Thank you for being here on Sunday. I know you've had a busy week, and I always appreciate, one, the claps for USAID. I spent 2 decades there, and when people introduce that as part of my professional history now, I get a lot of, yeah, so it oddly makes me feel good that everyone is fully appreciative of what USAID has done and hopefully will continue to do. I want to start today by, whoops, you're already ahead of me. So thank you again for being here. I want to talk about an issue that really lies at the heart of global progress. And as Rebecca said, that's governance. So whether we're talking about eliminating disease, fostering democracy, or building strong communities, governance is what determines the success or failure. It's not just a theoretical concept. It's a practical necessity for sustainable development. So today, I'll share how the Carter Center has applied governance principles to achieve real impact and what we as a global community must do to ensure that governance remains at the center of global health efforts. Here's a quick overview of what we're going to discuss and what I'm planning to cover. First, I'm going to introduce to you the Carter Center, our mission, which is about global impact, although we are doing a lot domestically now, and we can talk about that later. But it's how governance has shaped our approach for over 40 years. Next, we'll define governance specifically in global health, and that's why what it is, why it matters, and how it influences the effectiveness of all of our health interventions. We'll take a closer look at the real-world applications of governance through the Carter Center's work on disease elimination, and specifically looking at guinea worm eradication program, river blindness, and trachoma, which are 2 of our elimination control programs. And from there, we'll explore how governance extends beyond health through the public-private partnerships I think many of us, especially at research institutions, enjoy, and the link between neglected tropical diseases, NTDs, and the Sustainable Development Goals, the SDGs. So finally, I'll leave you with key lessons from the Carter Center's governance model, and I'll call to action for all of us to figure out ways to strengthen governance as a foundation for global health and development. So our visionary founders, as Rebecca said, we were founded in 1982, President Carter and First Lady Rosalind Carter. I'll say her name is Rosalind. Everyone mispronounces it, and I think now that she has passed, since she used to correct everyone, I feel like that's now my responsibility. It was really a simple but very profound belief. Our tagline is waging peace, fighting disease, and building hope. And we think all of those are fundamental to human dignity. It was established in partnership with Emory University, and we are committed to human rights, health equity, the prevention of unnecessary suffering. Its work is built upon 3 guiding principles: preventing and resolving conflicts, strengthening democracy, and improving public health. Since our founding, I'll just do a quick highlight. We've monitored over 125 elections in 40 countries to strengthen democracy and governance. Spoiler alert, we're doing a little bit of that here in the United States now. We have helped eliminate disease in more than 20 countries, proving that elimination is indeed possible. We've distributed more than 1.1 billion doses of medicine to fight neglected tropical diseases. We've led peace initiatives in war-torn areas, ensuring that governance remains a pillar of our long-term stability. And our work has shown that when governance is strong, we find that healthy outcomes improve, democracy flourishes, and communities thrive. So on a global scale, we have covered more than 80 countries in our work over the last 40 years on multiple continents. We only go where we are invited, and we strive to fill roles that are left unaddressed by others. President and Mrs. Carter were adamant that we fill niches, that we do not duplicate the roles of others, because, who else would have picked up guinea worm at the time or said that disease could be eradicated? So we do some moonshot concepts, and we are not risk averse. We take on some of these issues. I think now as we see the shrinking space, we're going to have to figure out exactly what the Carter Center in the future looks like, because so many programs that many of you are attached to are still necessary. excuse me, and they don't have the funding that they once had. So we will be, that is, 32 days behind, under our belt at this point. We're going to have to figure out exactly what comes next. The center remains committed to governance across two major programmatic areas, peace and health. We, in 40 years, have stayed true to those two areas. We have not jumped off to do other programming, and I think that that's part of the governance conversation Rebecca and I will have. So in our peace programs, we work to strengthen democratic institutions. We've been mediating conflicts and advancing human rights. As I said, we do some of this domestically now, the work we do in Sudan and Mali, we're doing in Arizona and Michigan. So we show that we need to hold a mirror up to ourselves as a US-based organization. We've done election observation, conflict resolution, and advocating for government transparency, and we ensure that governance structures support peace, just, and inclusive societies. As for our health programs, along with our mental health work, which was Mrs. Carter's intention when she started 50 years ago, along with our mental health work, we are working to fight neglected tropical diseases such as trachoma. Thank you, Dr. Martin. Such as trachoma, lymphatic filariasis, river blindness, schistosomiasis, and guinea worm disease. We are probably best known for our health program in our guinea worm eradication program, which reduced the ancient disease from an estimated 3.5 million cases per year in 21 countries in 1986 to just 14 human cases last year. Lymphatic filariasis, also known as elephantitis, can cause enormous irreversible swelling of the limbs and body parts. It's painful and often leads to people being ostracized in isolation, so we have combined that also with our mental health program in places like Haiti to ensure that people who feel isolated are also getting, not only physical help, but mental health. River blindness starts with, as many of you probably know, an unbearable itching that often prompts people to use jagged stones to try to get rid of it, and eventually that leads to infection and blindness. So this is part of our mass drug administration, which I'll talk about in a little bit. Trachoma is a bacterial eye infection that, if untreated, causes eyelashes to turn inward and painfully scratch the cornea with every blink. We're making really good progress in this. In 2023, WHO verified that Mali, with our assistance, had eliminated trachoma as a public health problem. These are preventable eye diseases, and this is why the public-private partnerships become so important, and governance at the Ministry of Health level become important. And schistosomiasis is caused by tiny snails that infect children's urinary tract, and it leads to severe health complications. And we help distribute a highly effective drug through Nigeria's schools that combat these diseases. Again, a tie into governance because the Nigerian school system is allowing us to do this. So not listed here is the International Task Force for Disease Eradication, which is a world body that analyzes public health challenges and identifies opportunities for disease eradication. The task force operates out of the Carter Center, and it serves as a global leader in strategic thinking about disease elimination efforts. The Carter Center's model is built on identifying these specific gaps in global health efforts and trying to find ways to fill them effectively. We don't duplicate the work of others, as I said, but instead our intention is to leverage our expertise and our partnership and our boots on the ground to advance disease elimination where it's most needed. So the foundations in governance in global health, to understand how public health initiatives succeed at scale, we really must look at the broader foundations of governance. We know that a well-functioning government framework ensures that health policies are effectively designed, implemented, and adapted to evolving challenges. We also know when the opposite of that happens, and we all suffer the consequences. So we're living in a time now where governance is being challenged in ways we have not seen for decades. The principles that underpin good governance, such as transparency, accountability, and inclusiveness, which are all vital for building trust and ensuring that health initiatives are successful and sustainable, must be there. That's the only way we can work together. And the current challenges to these foundations in governance include political instability, the erosion of democratic institutions, a weakened public trust, in governance at all sectors, and this especially includes public health. You know, when we started talking about this, I didn't think so much we would be looking inward, but I realized that all of you, as you're in this sector, are looking inwards. And so as I talk about the international applications of political instability, I know that we also have to consider what we are facing here at home. So these factors don't just affect policymakers, they directly impact global health, humanitarian aid, and international development. For an organization like the Carter Center, these governance challenges mean we must constantly adapt and be flexible. And in some countries, democratic backsliding has made election monitoring more complex. In other countries, political instability has disrupted health initiatives. And yet the Carter Center remains committed because governance is not just what we work on, it's exactly how we work. Surviving crisis is not enough. We must learn from it, and governance helps determine whether global health initiatives can succeed or fail. So the question becomes, how do we maintain resilience? Integration of governance into global health planning ensures program stability and sustainability. Aligning finance mechanisms very specifically with governance priorities prevents programs from collapsing when funding collapses. And ensuring transparency and accountability strengthens trust in health institutions. But what do we actually mean when we talk about governance, and why is it so crucial for global health and development? So let's start by defining governance. It's not just about governments. It's about how power and resources are managed to serve the public good. It ensures that policies don't just exist on paper, but they work in practice. The World Health Organization defines governance as the process of policymaking and implementation through shared responsibility among governments, institutions, and communities to improve health outcomes. So we can think of strong governance as having 4 pillars. Accountability, ensuring policies are followed. As a result, they are therefore achieved. Transparency, making information open and accessible to build trust. Inclusivity, involving government, civil society, and communities in shaping together these health priorities. And policy effectiveness, which is designing health programs that are long-term, data-driven, and set for adaptation. But governance is not just about government actions, as I said. It's about how institutions and international organizations collaborate to implement these solutions. It determines how resilient health systems can be during crises, and whether solutions can be sustained beyond short-term funding cycles. We all lived through this as part of COVID-19, and we're all probably going to be living through this, whether it's the measles or whatever breakout that we see when we're missing some of the backbone of our health systems. When governance is weak and they fail, the public health crisis increases. So if we care about sustainability in global health, governance must be the center of our strategies. So now that we understand specifically what governance is, let's explore how it directly supports some of the world's most pressing health and development goals. So everyone's seen this wheel before, the SDGs. So before we move into how governance specifically intersects with global health and disease elimination, let's take a moment to look at the Sustainable Development Goals, the SDGs. There are 17 goals specifically established by the UN in 2015, designed to address the world's most pressing challenges by 2030. And the goals range from ending poverty and hunger to promoting health, education, gender equality, clean water, and economic growth. They're interconnected, very much so, meaning the progress in one area impacts the success in another. At their core, the SDGs present a universal call to action that many people have been following and living by since 2015. Governments, organizations, and individuals need to build a more just and equitable and sustainable world. They're not just aspirational. They provide a very structured framework for all of us to work within on how policies and programs and funding should be directed to achieve the most measurable impacts. Governance plays a critical role in this, in determining whether these goals can be achieved. And so without strong governance, health systems fail on delivery, care, and equality. Development projects lack long-term sustainability, and resources do not reach the communities most in need. Good governance ensures that most of the countries can translate global commitments into real-world progress. One of the clearest examples of this is the fight against neglected tropical diseases, which directly supports multiple SDGs. So let's explore how eliminating NTDs contributes to achieve these goals. So as you know, NTDs are often seen as purely medical challenge, but in reality, they're a governance challenge. President Carter used to say there are no neglected diseases, there are only neglected people. And so this success or failure of NTD elimination efforts is directly tied to the policy decisions that governments make, leadership, and government commitment. So looking at this, how do the NTDs support the SDGs? NTDs affect over 1.7 billion people worldwide, most of whom live at poverty levels in rural communities. Eliminating these diseases is not just about improving health. It's about breaking the cycle of poverty and strengthening economies and improving education. So let's take a look at how governance-driven NTD elimination directly supports some of these SDGs. So SDG 1, no poverty. NTDs disproportionately impact the world's poorest populations, keeping people from working, going to school, or contributing to their communities. Elimination programs restore economic productivity, and all of that leads to the poverty levels declining. SDG 3, good health and well-being, ending diseases like river blindness and guinea worm and trachoma improve the quality of life. They reduce the healthcare burdens on the community and the country, and they strengthen national health systems because one disease elimination learns from the next. SDG 6, clean water and sanitation. Waterborne diseases such as schistosomiasis and guinea worm require investment in safe drinking water, hygiene, and sanitation. And these programs create long-term infrastructure and improvement. I remember as we were all looking at COVID-19 and washing your hands and making sure you kept your hands clean, we're dealing in countries that don't have water. They don't have clean water. And so if they're washing their hands in water that is dirty, then that is not actually increasing their ability to move past the disease. And so we, as ethicists, also have to recognize what's good for one country isn't necessarily good for all countries. But clean water and sanitation is effective control for almost every disease. SDG 10 reduces inequality, and women and children suffer disproportionately, as I mentioned, from NTDs. In many communities, women happen to bear the burden of caregiving for family members suffering from preventable blindness, disfiguration, and disabilities. So the governance link between NTD eliminations and SDGs is quite clear. NTD elimination does not happen in isolation. It requires strong national policies that integrate NTD treatment and prevention into universal health coverage, cross-sector collaboration, where ministries of health, education, and water work together to create sustainable health infrastructure solutions. Public-private partnerships, ensuring that medicines, diagnostics, and funding mechanisms remain available in the long term. So, and as I mentioned, a powerful example of this is our International Task Force for Disease Eradication. Because we bring together donors and implementers, we're having those conversations along with Ministry of Health officials. We're having those conversations about what can raise to the level of elimination. What can we put in the docket to suggest that everyone can buy into this and we can have national health strategies? So let's look at how President Carter's legacy and leadership and commitment to governance helped lay the foundation for some of the successes that we have had in our global health work. President Carter's legacy is quite clear. He understood that governance was not just a tool of political leadership. It was not a tool for only public health, diplomacy, and human dignity, because those were the pieces that were important to him. One of the most powerful examples of governance at work was the guinea worm ceasefire in Sudan. So in 1995, Sudan was in the midst of a civil war and millions were displaced. and there were areas that were endemic to guinea worm. And President Carter personally negotiated the ceasefire, not for political gain, but for public health. And during the 6-month ceasefire, the longest ceasefire in Sudan's civil war, it allowed us to send health workers in to meet some of the remote places and distribute filters, water filters, educate communities. It was the first time in history that a ceasefire was brokered for the purpose of disease control. We always talk about humanitarian corridors to get food in, but we don't always talk about humanitarian corridors to address disease control. But that was governance in action, and leveraging diplomacy, leadership, and trust to improve health outcomes was how President Carter approached this and how we at the Carter Center continue to. So let's look at how we apply these governance principles to other health programs. So when we talk about global health, when we talk about governance in global health, disease elimination provides some of the clearest examples of why it matters. The Carter Center has dedicated decades of work to tracking guinea worm disease, river blindness, trachoma, and mental health challenges. And it's not just through these medical interventions I talked about. The key to success has been strong governance structures, working hand in hand with national ministries and with local communities. So I'll give you what I think is a governance success in guinea worm. The ancient affliction, which once crippled villages, preventing people from working, going to school, and taking care of family and farming, the Carter Center took on this fight in 1986. Again, an estimated 3.5 million cases in 21 countries a year, and we're down to 14 cases this year. At the time, many believed guinea worm couldn't be eliminated. There was no vaccine, there was no cure. It was only about prevention and behavior change. But what seemed impossible has actually shown to be the biggest governance challenge we've had. It's not a medical one. Carter Center's approach has focused on national ownership, working through ministries of health, embedding guinea worm surveillance into government programs, and embedding the Ministry of Health into the Carter Center programs. Community-led solutions, we have trained tens of thousands of village volunteers to report cases and to ensure safe water interventions. These people feel empowered that they are part of their community now, and they are ridding their villages of guinea worm. Accountability mechanism, implementing a real-time reporting system to track every case and ensure follow-up. This wasn't just a public health intervention, it was a governance intervention. And we worked beyond the end of the road, reaching very remote communities where health systems were often non-existent. By embedding the guinea worm control program in the national structures in these countries, we created a system that would outlast any one funder. And it was because of this long-term commitment and national leadership that the disease is set to be the second human disease ever eradicated after smallpox. And again, done through behavior change, because this is not something that has a vaccine or a cure. River blindness has been part of our sustaining public-private partnerships. Another example is river blindness, of course, is a parasitic disease that once left millions suffering as they tried to scratch their way out of it. So it was either a bacterial infection or the actual blindness that caused river blindness to be such a major issue. We have supported national elimination programs across 10 countries in the Americas and in Africa, and the challenge wasn't just delivering the treatment. The challenge has been ensuring that governments took ownership and built sustainable treatment programs. I just got back from Latin America. In the Americas, we have a very small pocket, indigenous population of the Yanomamis. We have gotten rid of river blindness throughout the Americas except in this small, remote area. And if we can't get the help of the Brazilian and the Venezuelan government to reach them, it becomes a governance issue. It's not that we don't have the ability to make a difference in their lives. It becomes a governance issue on how we reach them. So a key breakthrough with this particular program was the Mectizan donation program, which was launched by Merck in 1987. And the company has pledged to donate ivermectin, Mectizan, for as long as needed. And the distribution was left to the government and implementing partners. And so you find public-private partnership where they make the donation, but they leave it in the public hands to get it out. And that has been something that we've looked at through all of the drug donation programs that we all work on together in the implementing community. So the Carter Center's role, very specifically in this, was to train community-directed distributors, ensuring that even the most remote populations receive treatment. We support the ministries of health in developing long-term plans, and for the Mass Drug Administration, we monitor program impact and strengthen national reporting systems, and the result has been several countries in America and Niger have eliminated river blindness, and multiple African nations are on track to follow. Again, the success was not just about medicine, it was about embedding governance structures into that ensured the long-term sustainability. I'll just briefly mention trachoma as the national strategy for trachoma, another devastating neglected tropical disease. It's been the leading cause of blindness worldwide. And we began fighting this in 1998 using WHO-endorsed SAFE strategy. That's surgery to correct the blinding, the cause of the eyelid turning inward, antibiotics donated by Pfizer to treat the infection, facial cleanliness campaigns to prevent reinfection, and environmental improvements, including building latrines and better water and sanitation. One of our most recent milestones was in Mali, the elimination of trachoma as a public health problem in 2023. It was a feat achieved through years of partnership with the Malian Ministry of Health and local communities. It's just another case study in governance. So mental health, I would say that the mental health policy, as I mentioned, this was Rosalind Carter's, This was Rosalind Carter's specific work. The NTD elimination shows that it can be done, and tangible and measurable results in health outcomes. Also, mental health presents even a greater governance challenge. So for decades, mental health was simply not a priority for most national health systems. Funding was scarce, policies, I'm like touching this too much, I guess. Funding was scarce, policies were non-existent, and stigma was widespread. In many places, there were more prison beds than psychiatric beds. A perfect example of how governance can shift mental health care is in Liberia. So when the Carter Center began, there was one trained psychiatrist in the entire country. And Ellen Johnson Sirleaf asked us to come in, and she was about to retire, asked us to come in and look at the psychiatrist, not Ellen, to look at how we could train the psychiatrists throughout Liberia. It was one practitioner with 4 million people in the country. So we helped them establish the first mental health policy. We trained the first cohort of mental health clinicians, and we have worked to integrate mental health into the national health system. We now have over 300 trained clinicians in Liberia, and we have an app that you can find them. If you're looking for Chinese food here in the States, you can find it wherever you want. In Liberia, if you're looking for a mental health professional, you can now find it on an app. So governance shifts cultures, and when governments make mental health a priority, funding tends to follow. So policies improve, communities recognize mental health as essential to public health and destigmatize it, and that's the next frontier of governance and global health. We've seen how it plays a role in disease elimination in mental health systems, but the Carter Center has not done this alone. Public-private partnerships have been essential to sustaining these efforts. So just a bit about the public-private partnerships. One of the most powerful ways to sustain long-term partnerships have been what the private sector has offered up. These collaborations tend to bring together governments, nonprofits, corporations, and communities to tackle some of the world's most pressing health challenges. But the key to making these PPPs work isn't just funding. Again, it's governance. Partnerships that succeed are those where the roles are clear, accountability is strong, and sustainability is built into the model from the start. Carter Center has leveraged public-private partnerships across all of our health programs. It ensures that governments remain in the lead, and while private sector resources are used, they are done so strategically and for long-term impact. You know, I'll mention guinea worm just as aside. We worked with DuPont early on because they produced these water filters, and they were much better than the cloth filters. And once we approached DuPont about it, they actually closed an entire system that they had and presented to us millions of square feet of nylon filter cloth. And if that had not happened, if we had not been able to get that going when these countries were in such endemic need of being addressed, their entire production line was geared towards us. We have this with Merck as well. They have an office in Haarlem, Netherlands, and it only produces 7 days a week the Mectizan pills that we need for our river blindness program. So philanthropy can help solve global challenges, but it also has to be beyond philanthropy. So I would say that today these partnerships in several countries in the Americas have completely eliminated the river blindness issues that we had, and multiple nations in Africa are making significant progress towards elimination. Because of this, funders like Gates and Children's Investment Fund and UAE have taken a big bet to say if you can do it in the Americas, you can do it in Africa. And so those are additional big bets that are being taken. And that's when funders lean in, when they see success. So, whoops. So that's where private funding kicks in. Key takeaways from the public-private partnerships, I would say the most successful ones are those that first, align with government priorities rather than operating in parallel. Secondly, they empower local communities rather than relying on external actors. Third, they have long-term sustainability built in, so they ensure that programs don't collapse when the initial funding ends. And the Carter Center believes that governance, again, is the foundation of all these successful partnerships. So let's step back to reflect on a broader lesson that governance can offer the global health community. We can, as leaders, learn from the fact that governance is the foundation of health systems. Sometimes we ignore that. We think as medical professionals, or you all think as medical professionals, that the answer is always going to be medicine, that there's always going to be that backbone behind it. But we think that it's truly a governance issue. Without strong governance, health programs will collapse. And it doesn't matter whether you've got the medical science behind it or the funding behind it. If you don't have the governance behind it, it won't succeed. We all have to be leaders in ethical decision-making matters. We operate at the Carter Center with neutrality, transparency, and a focus on sustainability. President Carter's guinea worm ceasefire in Sudan showed that governance isn't just about rules, it's about trust and leadership. We had the same issue in Liberia with Ebola when CDC walked in trying to tell leaders that they couldn't bury their dead that way because they were spreading the disease. They weren't listened to because they were just coming in as somebody who was new. But we had been there for 20 years. So through our peace program, we were able to have those conversations and say, how can we stick to your religious norms in burying your dead, but you wear PPE while you do it, and you rotate every 30 minutes. So those are the kind of conversations you have to have. It's not just science-based, it's not only governance-based, but it's also trust and transparency. Community engagement is, of course, key. Our health programs fail when communities are left out. There are a lot of things we would all like to tackle, and we can see when we come in from our perch what needs to be done. But if it's not in the community interest and they don't want to do it, there are plenty of development programs that have failed around the world. I think about some that I had worked on where you're building wells in the Middle East, and the women don't want the wells built. They want to be able to get away and collect the water. They don't want to collect the water in the backyard. So these are the type of issues that you have to recognize that we might see on the ground, but it's not what the communities want. And if their engagement is not part of it, it's not going to work. And public-private partnerships must be structured for long-term success. So these lessons apply not only to NTD elimination, but to pandemic preparedness, primary health, and health equity worldwide. So as we conclude, let's reflect on why governance must remain central to global health efforts. I want to leave you with these words from President Carter. As he said, he has one life to live and one chance to make it count for something. He lived it for 100 years. He was somebody that did what he thought needed to be done, whether it was politically sustainable or not. He always listened to the people at the end of the road because they looked a lot like his village of 600 people in southwest Georgia. And this is why the Carter Center continues to be founder-inspired, even though we're not founder-led anymore. But the words capture the strong need for governance as well. And we have seen how good governance provides stability in crisis. It has fostered resilience in communities, and it ensures that the most vulnerable are not left behind. We saw in villages once plagued by guinea worm disease where community-led governance structures help bring the disease to the brink of eradication, and we see it in mental health programs now where strong policies ensure that care is available even in post-conflict settings. And we're going to have to look at it in our own backyard about how our effects and the work that we do elsewhere needs to take account of us putting on our own gas mask first and also being able to help those most in need. So the lesson's clear. Governance is not just a structure, it's a commitment to doing what's right, even when it's difficult. This is the legacy of President Carter. He believed that people, when empowered, can lead change in their own communities, and he believed that governance at its best serves the people with integrity, humility, and a vision for the future. And now it's up to all of us to carry that forward. So thank you.
Derek, if you wouldn't mind turning the lights up, please. Thank you. So what we're going to do now is we're going to shorten our fireside chat, but we have a few questions we'll talk about. And then, because I do want to leave room for the audience participants here, we have students, we have scholars, we have people from all walks of life, from programs. So I want them to have a chance to speak with you as well. But I do want to ask you a couple of questions to start this off, and then we'll wrap up. But I was telling you earlier that these last 3 days have been very inspiring, bringing the global health community together, recognizing that there's lots of threats, both internally and externally, facing us. But there's been a sort of community here, and I think your remarks today talking about the success and progress that the Carter Center has made in partnership from communities to global level is just so inspiring as well. So thank you very much for that, and look forward to that. I wanted to start with a question, and I cleared it by Ambassador Jimmy Coker first. But yesterday in a panel, he said, somebody was talking about the global health architecture. And when he had a chance to make a remark, he said, I'm not sure it's so much global health architecture, but maybe a big traffic jam, a global traffic jam. And he said, we don't really have the lanes for when we need to go fast, like the high occupancy lanes or the bike lanes where we could find different ways of getting places. So in hearing about all the success and innovations that have happened with Carter Center and moving forward the incredible work you have, what innovations do you think are important in governance, in global health governance, in being able to move this forward to achieve global health goals, and then as well ensuring that we have community and local leadership, which you talked about quite strongly?
Yeah, I think it's true. I think culturally we also have to look at the fact that it's not a one-size-fits-all. You know, what we think is needed and what a country needs are often quite different. And we do fall all over each other. Implementing partners all the time are trying to do the same thing, duplicate efforts, trying to hit up the exact same funders to do the work. So we have to get better at communication. I would say that the contraction in this field that we are all feeling is probably going to make these conversations more viable because they're important. It's the only way we're going to get to the people that we're trying to work with. As I mentioned, the example of development failures from around the world, whether we were sending pigs to Haiti when I was at AID and they weren't able to survive, or sending cows to Siberia that weren't able to survive, you know, we have made major mistakes in the development field, and we have made it in health as well. If you do not have community buy-in, there's no chance. If you do not have Ministry of Health buy-in, there is no chance of success. And those are kind of the two issues that President Carter understood. You know, trachoma was in Plains, Georgia. When he was growing up, that actually existed in Plains, Georgia. So he knew the people at the end of the road just wanted to have this partnership. They did not want to be treated as if they had to have this assistance. They wanted to explain, for guinea worm, how you tether a dog or how you tether a cat to make sure they don't go into the water source and spread the larva. But we had to do it their way. So I think that part of the problem is we don't talk as much among ourselves. The bike lane that works in Amsterdam does not work in Atlanta, Georgia, I'll tell you that. So you have to have different bike lanes. And I think that we all have to be much more sensitive to the cultural norms, the cultural needs, and including, 99.99% of our 3,400 staff overseas are local. I think that we're going to see a collapse in this field of that people are going to have to start relying more on local staff, and I think that that's a positive.
No, that is a positive because, as you said, that's where the sustainability will be. So absolutely. So I want to build off this a little bit because you started to allude to this. We've had some discussion here about reimagining global health, and governance has been a big piece of that. But thinking about the current shifts in governance and what we're seeing in the geopolitical issues, what do you think are some of the emerging issues that we need to be careful to make sure that we address that are critical? And then what are some of our biggest threats that we're facing?
Well, I think denying science is probably the biggest threat we're facing. When you start looking at zoonotic diseases and things that are jumping from animals to people and vice versa, I think we don't even know what's behind door number 3 for that. So, I mention that and I actually get chills because I am not an epidemiologist, I'm not a medical professional, but what I have read on this is frightening. And so as we degrade our scientific knowledge, our research and development, and our staffing at important places like CDC, we're really going to be facing this fear. We've got it in Texas and New Mexico now with the spread of measles. And so as you're denying vaccines, or as you're changing state laws as to what people are walking into school, your children are walking to school and then bringing home to you, it's going to be a problem. So I see a lot behind door number 3 that scares me, and I'm hoping that the system can address it.
No, it's really important. And we were talking yesterday, we had a global health debate about whether academia should be involved in the politics as well. So we talked a little bit about that. So when you first arrived in Atlanta in June 2020, there was a lot going on in the US and in Atlanta itself. We had COVID-19 pandemic, and we had just seen as well the killing of George Floyd and racial injustice issues going on. So I wanted to ask, as you're coming in to be the CEO for Carter Center and thinking about what your vision, while you said it's founder-led and now founder vision, what was your vision, and where have you taken that since you've been now in your position since 2020 and thinking about how to engage domestically and from your experiences and work and what you've seen overseas to be able to bring to this work here in the U.S.?
Well, I came in, I had been living in Europe for 3 years, and I came to Atlanta in June 2020, so in middle of the pandemic, middle of the racial justice protests that we were seeing, and coming back to a hometown that I had lived in. My parents live here, my 3 older brothers live here. Atlanta's home for me, but I had not lived here. As my parents said, I had been visiting other places for 35 years. So I get back to Atlanta, and I go down to Plains to see President Carter, and I said, how exactly are we doing election monitoring overseas when we're not looking at the 5-hour lines in Fulton County? Like, how can we be honest with ourselves if we're going overseas and shaking our finger about election integrity when we've got questions about that here? And so he had pointed out to me, when you walk in with a Carter Center shirt on anywhere in the world, everyone's excited to see you. Even if you're doing election monitoring, the international observers are here to tell everybody that we did this right. When you walk into Fulton County with a Carter Center shirt on, you're like, go to the Democrat side. So we are already come with this, supposition that we are Democrats, but we are a nonpartisan organization. And so as you had the COVID-19 mess of denying science and everything that was happening, he said, if you go in, you need to be bold. You need to do something that no one else is doing. And so that's where I've been trying to find the space for us for the last 4.5 years, because we had spent 36 years doing international development. So how do we bring that back home? How do we hold a mirror up to ourselves? And I think one of the main things I've learned is what we learned in Mali and Sudan. I can't do a conflict resolution program in Arizona and Michigan based on how we treat things in Georgia. We need Arizonans, we need Michiganders, we need Wisconsin folks to run their own programs. And so we're taking those lessons of community-led and based changes directly to the community. And I think that's, again, part of governance. You can do it from the federal level, you can do it from the state level, you can do it from the community level. And all of us have a role in plugging in at one of those levels, whether we're trying on the policy side, we're trying on the state side, or we're trying in our own community by talking to your neighbors. So that was the change that we had in 2020. But I'm still struggling. I mean, this is an earthquake to our sector, what has happened the last 32 days. And how we all react is going to be very telling. And I think we need to do it in a collegial way that has not always been indicative of the public health sector, because everyone is fighting for their own research dollars, for their own implementation dollars, and we need to get better about that.
And I think that, and it goes back to the traffic jam. It's like, let's get out of this and let's get those lanes moving. All right, I'm going to ask you one more question, and then I'm going to open it up. So if you'd like to get to a microphone, and if you have a question, please state who you are and where you're from. But so my last question, and you alluded to this a bit, is thinking about the governance, working in peace and working in health. And going into a community to work on health outcomes such as eradication or elimination. And you mentioned this a bit with the guinea worm, is like, which comes first? Does it? And then how do you make sure that these two efforts in governance, in peace and in health, how do they reinforce each other?
Yeah, it's hard to know which comes first, because when you're at the community level, you hold up a picture of the president of the country, they have no idea who it is. You know, they don't even have pictures. They're not watching TV, listening to radio, or anything else. So for them, governance is a totally different meaning. It is, what is the governance of their village and their community? And so listening at the end of the road is a very different answer than what you're going to be working with the ministries on. But we can be that glue and that synergy between a ministry and these far-flung areas. So we often run into trouble. I mean, Ethiopia, when you're trying to do an election observation and you're also trying to do trachoma elimination program, sometimes they fight each other, and the Ethiopian government's not so keen about having eyes on their election, but they really want the mass drug administrations in Amhara and elsewhere. So it's a thin line. And I'll be honest, we also take funding from UAE and others who are doing such amazing work in global health, maybe not so much in other places. And so as we work in Sudan, and we have to figure out, what does that look like? So it's hard to tell what comes first, but the most important thing is listening to people at the end of the road tell you what they need.
Perfect, thank you. So I'm going to open it up to see if there's any questions. Please just go to the microphone and state your, yes, please, in the middle here.
Hi, my name is Allison Spenceley. I'm a doctoral student at the University of Alabama, Birmingham. Thanks so much for talking about the democracy and leadership work that you're doing. I think, especially right now in our world, the leadership and democracy work at the civil society level is just as important. We've tended to take a very project-based approach to implementing health programs or research projects, and I know that USAID and PEPFAR had a very long history of trying to bolster leadership and governance at a very local level in order for communities to decide on their priorities, what they want to achieve, and to create the governance to allow that to happen. In reality, what that meant was working with smaller organizations to improve their business planning, their compliance efforts, finances, really a lot of stuff that's just not very sexy in our world, and also is not funded. It does not seem to be health related. But I do think that that work is critical for the sustainability of any of the gains we want to make in public health. So it's a challenge. I guess I just wanted to ask if you have thoughts on how we can expand the work that you all are doing at a national level down to regional, district, community level in order to make, hopefully, permanent gains.
I would say proof of concept. When you have a success, it is scalable, it's replicable. So you have to have that first success, and then you have to do something that we practitioners aren't always good about. We have to communicate it. We have to make it very clear that this was a success and it was done for X, Y, and Z reason. And so you can take it to another level and make sure A, B, and C get done as well. So it's hard. We've also seen building off those successes. I'll say with guinea worm, some of our research and development and diagnostic and genomic testing, that is going to lead to other successes in neglected tropical diseases. And so you have to find those successes and we have to talk about it. We're just so bad in this community about, we come into work every day. We love the work we do. We know when we're successful. We know when people are getting fed, when they're getting immunized. But we don't talk a lot about giving out 1.1 billion doses of drugs. Like, we're just not as good at it. So I do think that part of that is the messaging. And that's something this community has to get better about. And we're trying. We've learned nothing in the last 32 days. It's that we have to get better about our messaging. And so I think that hits at the community level. And I'll say this, not to get political, but there was a town hall in Roswell, a couple miles down the road, and the member of Congress got attacked by the CDC cuts and what is this going to mean for our kids in school? People are suddenly starting to realize that it affects them at their level. The Kansas State Farmers Association, 47% of their crops are sorghum, and 100% of that goes to Food for Peace. Kansas is now speaking out. So we have to find our voice is kind of the answer, not in protest always, but in support of successes.
And I've seen this too. University of Alabama, Birmingham has strong support from one of its senators, and she was saying the same thing. These are my constituents. These are people in my community. So really important. Yes, in the middle, and then we'll go over to my right.
Hey, thank you so much. My name is Atusa. I'm from UCSF. This was really inspiring. Thank you. My question is regarding the countries that you haven't had any projects yet. So I wanted to know more if you've tried to build the conversation with the governments within those countries and that they rejected. And if so, what steps you think should be taken to build the trust and the dialogue within those countries, since I guess that some of them at least are politically unstable or sensitive. Yeah, thank you.
We only go into countries that ask for our assistance. I mean, that's how that has been the aperture through which we've looked. Even though if we know there's work needed in a specific country, unless they're coming to us and saying, we'd like your help, we already know we're going to be starting behind. We're going to be selling them something they don't necessarily want. And there are enough countries that do want our help. So to be honest, we've been less aggressive in that area than maybe we should have. But there's a lot of work to go around, so everyone can be doing it.
All right, thank you. Over here.
Hi, my name is Victoria Short, and I'm a master's student at the University of Georgia. So the Carter Center is at a really interesting intersection of democracy, health, and peace, and something that runs rampant across those pillars is disinformation. So I was curious if you had any advice on how we as researchers and practitioners could address that disinformation.
I'm hoping that's why you're in school, and those are the answers you're going to give us.
I'm actually a journalism student, so yes, this is my little wheelhouse. I always ask about it.
I tried to explain to President Carter what a bot was. I was like, I'm in my 50s, you're in your 90s. There's no reason the two of us should be having this conversation. But you have to understand, social media has taken over. It's turned the social media has turned political landscape into some farcical being of a difficulty to tell fact from fiction. And I said to him, it's like putting bad words about you up on a tree that's just high enough that no one in the village has got a ladder to get up that high to take it down. But it's everywhere. And I said, so people are just lying. And the disinformation and misinformation is not being countered. As I was saying with Allison, it's not being countered effectively from our community. And I don't know how we get those messages out, but we've seen it in science denier, vaccine denying, concerns that people have, legitimate concerns people have about vaccines. the questions need to be answered. So I think it all comes back to civic education. I'm a big believer that our kids have not been taught this, and so they're not nuanced learners anymore, and they believe whatever they see in the first 120 characters. And so we have to get better at that. But I do hope that's why you're in school and you're going to come and help us figure this out.
Thanks.
Yeah, I was talking with somebody from this conference, and the same thing. It was like, ask where this is coming from, and why would this person put this out, or this group, and that's really critical. Yeah. Okay, into the middle. Thank you.
Quentin Eichbaum, Vanderbilt. Many projects fail because we go in and we don't take sufficient time to fully understand the culture in those countries. The Carter Center works in so many different countries around the world, and I understand in many of them you've had a long engagement, but I'm still curious, other than just partnering with the local people, do you do anything proactively to better understand all those cultures that you're working with?
We do. We work with bioethicists at Emory. We work with folks, as I said, 99.9% of our staff are local. So we're not sending in an American chief of party to say, this is how we're doing it. We are actually organically letting these programs grow. You know, is it best to give MDAs at this time of day, at that time of day, on a weekend? You know, is the Ministry of Education going to allow it to happen at school, or are we going to have to do it separately? So it's not a one-size-fits-all. But before I took this job, I remember in the middle of COVID when we were all watching TV about anything and everything that you could find, there was an interview that I think David Letterman did with Melinda Gates. And he said, what is the best advice you've ever gotten? And she said, from Jimmy Carter, when he said, hire local. Don't think that you can take our brilliance and put it into a cultural situation, because it will never be bought. And so for us, it's been a learning curve of 40 years that, again, not one size fits all. And we do things very differently in West Africa and East Africa. And that's just the way the program works. But it's tough. It's tough because we, of course, think we know how to do it best. And if they would just do it this way, it would happen so much faster. And it's just not going to be internalized if we do it that way.
No, it just seems to me initially you need to go in and sort of understand. Once it's up and running, you're using local people. So I'm still curious up front, there is that initial engagement. But you probably have a lot of experience. I'm not insinuating one size fits all. In fact, they're highly contextual, the different cultures. So, and I don't think it's an ethics thing. I think it's more an anthropology, cultural kind of issue.
Well, it's also governance.
Yeah, governance. Yeah.
It's very much governance. I mean, the whole intention of this talk is, where does governance lie at the intersection for implementing our programs and what the government will accept? Because if you're fighting against the government, you're never going to get anywhere. I was talking to one of our funders who has all of their medications sitting in a port in Nigeria, and the Nigerian government has suddenly decided that they're not going to accept that because they can produce it locally. And the funder's like, you will get no new medications from us ever if you let these go to waste in port. And so sometimes it comes down to the tough love message, but also listening. If they can produce it locally, perhaps we should be buying locally instead of taking the donated drugs from here. And so it's a negotiation tool. So whether politics plays into academia or not, everything is political. You know, everything is political.
That's a hand clapper. Okay. I think we have time for 2 more questions, so we'll go over here first and then to my right.
My name is Jamiu Olabamiju from Nigeria. And
There you go.
you know, my comments and a kind of question I have is actually around allowing the government at different level to play a coordinating role in implementation. That is one major area where we're getting it wrong. At different level, like Nigeria that you mentioned, for instance, we have the local government down there, we have the states, and we have the federal government. And if you don't allow them to play a coordinating role, you see all different partners duplicating effort, doing things in silos, and there will be no good coordination. And if this discussion actually happened and the government is involved right there at the point at which we are trying to even discuss what you want to implement in the country, they will be able to tell you the available resources in the country, that these are the things that are already existing. So these are the gaps. Then whatever your implementation will be addressing the gap. Because at times I wonder, whose problem are you solving in the first place? When you just come into a country and you don't even understand the landscape and you just want to implement. So having that discussion with the government and allow government to play a coordinating role is actually key, which goes to your last comment. Thank you.
Thank you.
Wonderful. Okay, last question over here, please.
Hi. So this is not so much a question, but you know, I want to commend the Carter Center for mostly being local. But my name is Mwakali Kamami, and I am a recent graduate of the Emory School of Rollins School of Public Health. And I have a very difficult time with some of these conversations. I am Kenyan, and sometimes when we have these conversations, it feels like you're talking about us and not having a conversation with us. Because, you know, I've been hearing a lot in this conference that we are, quote unquote, reimagining global health, and I feel like this is much more of a global health reckoning for those of us who are standing from the global south, because we have been telling you, hire local. We have been telling you, invest in us. And now all of this is coming to a shock to many of you whose institutions are now saying, well, now we have to rely on the local population, which is kind of a bummer because you should have been doing this all along, and we are the ones who are going to have to suffer as a result of that. And I keep hearing about like, oh, well, the data, the science, we need to follow that. We have been knowing that this is the way to go for a long time. And in this reckoning, I really want us to really try and focus as to why we've been talking about decolonization as, oh, it's gonna take a long process and not a sense of urgency. When decolonization happened within the African countries, it happened very, very slowly and then all at once. And now as we're working to try and figure out decolonization in terms of a global health, it feels like it was happening very slowly, and now it's going to happen all at once. And I want us to start having different conversations about this, because like my brother over there said, the idea of having to rely on our governments is gonna become absolutely important. And we should have been working towards this until this point. And so for me, as many of a lot of people are panicking, I am feeling extremely disappointed and extremely let down by the communities that we have in global health, because we knew better. Many of the scientists and the people in here, we knew better, and we did not do what we were supposed to do with a sense of urgency. And that means that a lot of people are going to die, and a lot of people are going to have to train very quickly, when previously we should have been working on this all along. So I hope that we're all ready for whatever task is coming ahead, because we have a global health reckoning right now.
You're absolutely right. And you said it perfectly. It's a reckoning. It's not just a realignment. You have to understand human nature being what it is, though. This is an industrial complex. Global health, public health, we have all been brought up to do the work that we thought we were trained to do, to help the people who we thought we were helping, and we haven't been listening. And so there is, the shrinkage of this space is actually, some of it is going to be very good. But do have compassion on people who spent way too long thinking we know what's best. I grew up in a generation that I was on the other side of that, and listening in the field, having lived there for a long time, they know what's best. And we need to find a way to listen. So I think the reckoning that's happening, I mean, it's just like George Floyd, anyone will tell you this was also a reckoning. This wasn't suddenly. No, it's not suddenly. This is a problem that we've had for quite some time. And so I do hope that the contraction that we feel is somehow going to make us realign and have a reckoning with where we put our emphasis and who is empowered in this process. And so thank you for your comments, both of you.
Thank you. All right, I want to give you a moment for any final reflections on the path forward for thinking about sustainable governance in global health, and then we'll wrap up.
Yeah, thank you. I would just say that we all need to think about how to talk about our successes, the proof of concept, things that have worked. How do we replicate those as opposed to just replicating what we know? let's replicate what's working and let's talk more effectively about it. And from the peace side of the house at the Carter Center, I would say, talk to your neighbors. You know, everything is very polarized right now. And there are places that you can come together with people that you have very different political views with, or even very different scientific views. You will find space where you can talk. And I think that that's the most important thing we can do. And it's got to be done at the individual level and the community level, because I don't think we can expect our federal level to be taking care of this. So I think we should all feel a bit empowered now to actually make some changes that, as you were saying, are necessary.
All right. Well, remember, go local, and governance is how we do the work. And I just want to thank you, Paige, for your time this morning and for this wonderful discussion we've had and the incredible work of the Carter Center. So thank you, and thanks to the audience for your active participation. Thank you.
Thanks.
That was outstanding. You just put the cherry on the top of this. That was unbelievable. For sure. This is going to fit just perfectly what we're doing now. So you set us up.
Female badassery.
I'm not feeding it. Yeah, I joined the club.
No.
Catch up after. Yeah, please. Do you want to take a picture together? Sure. Good. You go in the middle. You're right. Oh, sure.
I'm gonna hide my notebook here. Thank you.
Thank you very much, Paige.
All right.
Thank you, Rebecca.
Bless you.
Wonderful. Bless you.
All the things are down here. Thank you, Derek.
Yes, please. Okay. Yes, thank you. Yes, or even 3 is fine. 3 is good. Yeah. Hi, everybody. Please, we're going to go right into our next. Oh, sorry. Yeah, you betcha. We're sharing your work globally, just to let you know. We're going to go right into our next session, everybody, next plenary, and it's going to be a wonderful addition to what Ms. Alexander just said today. So please, if you could stay in your seats or come back to them very quickly. And I'd call our speakers up, please, Professor Berman, Dr. Strasser-Michaels, Dr. Siwan Kambo, Professor Gruskin, and just a note, folks, which is a wonderful challenge that Ms. Alexander gave to us, is how do we communicate? Well, we happen to have at 1:30 today, room 205 at 1:30, we're going to have a special workshop on how to address the disinformation challenge that Ms. Alexander spoke about that you're all fully aware of. It's a communications workshop run by the Pulitzer Center and Global Health Now at Johns Hopkins University. We'll have an amazing group of journalist scientists that are going to get into the details how we can be better communicators and address a number of challenges, including the disinformation challenge that is before us. And we'll start in about 4 minutes. Please make sure we have a survey on the VFairs app. What we really want to do is to find out how we can make, of course, our conferences better in the future. And we hope to see you, obviously, next year, April 9th to the 12th in Washington, D.C. So a great place, given the circumstances that we're in. But on the VFairs app, there's a survey. Please fill it out and let us know how we can make our next conference better. So we really appreciate your input. The panel openings will probably happen around July, end of June, July. So be aware of that. It'll be on our website. And if you're a member of CUGH or you sign up for our website and newsletter at cugh.org, you'll be able to get the information. Please keep aware of that, and we look forward to your panels so that what you want to have done in Washington will be represented. So just keep an eye on that for the summer. We'll be going right to 1 o'clock, so it's a little bit short than that. Discussion and lots of time for track here. So good morning, everybody. Wasn't that a fabulous plenary with Ms. Alexander? And I said to her before we had never met before, and I said, you know, in my last job in Parliament, what I would do is come and steal all the great ideas from the United States, take them back to Canada, and see how we could implement them there and globally. And one of the things that I admired so much is I used to pay very close attention to what the Carter Center was doing. And I was so impressed by the work they were doing. They were, obviously, as you heard from her, it's about people, it's about relieving suffering, it's about waging war to make the world a better place, as was said by both President Carter and Rosalind Carter. And I think that's just what we've heard over the last 3 days. That was just an incredible, I hope, for all of us, a very positive message forward that we can work in a nonpartisan way to really improve people's lives. And finding that place in the middle, regardless of political stripe, is the place where we can work on to be able to accomplish that. And much thanks to Dr. Rebecca Martin for her outstanding emceeing and moderating of that panel. Thank you, Rebecca, very much for doing that. So what we wanted to do on this final panel is, I think when we started this, perhaps many of us came here shell-shocked about what was happening. And I hope over the last 3 days that all of us have come out with a renewed sense of purpose, and that all of us know that we're not alone and that we have a wonderful community here together, and we're all working together to be able to wage a better world for all of us. And I think Ms. Alexander's comments certainly move that in that direction. And what we wanted to do in this session, this closing plenary, is to really hear from some experts, their words in terms of how we can actually move forward, to build forward better, to achieve those goals, to make the world a better place, to improve people's lives, improve health, and improve the health of our planet. And we're going to do that. So we'll have we'll interrogate this question from different perspectives, and then we're going to turn it over to all of you to tell us what we can do at CUGH to be able to work with you to achieve that example. I thought what was really obviously outstanding with Ms. Alexander's intervention, and why we asked her to do this, is to really talk about the issue of governance, the foundation of development that we tend to ignore in global health. And with the current assault on governance that's happening not only here but around the world, it's ever more important that I think we work with other partners to be able to strengthen those systems of governance that actually underpin the ability of any of us to do the work that we want to do. So the consequences of having poor governance we've seen, but the consequences of good governance she laid out quite nicely. And she also showed, and if you have a chance to go on their website, to look at the human stories of what it means to actually address river blindness when it's not treated versus when it is treated. The human lives they've touched in so many ways is really jaw-dropping, and they've relieved so much suffering around the world. It's a remarkable success story, working with communities wherever they happen to be. So today, we have an incredible panel. We have Dr. Nelson Siwan-Kambo, who most of you know. He is the former principal of Makerere University of the Health Sciences, and the current president of the African Forum for Research and Education in Health. We have Professor Sophia Gruskin. Professor Gruskin is the director of the Institute of Inequities in Global Health and the Distinguished Professor of Population, Public Health Sciences and Law. She is a lawyer by trade, and we were very lucky that Professor Gruskin was on the Executive Planning Committee for our conference in Los Angeles last year. Dr. Susan Michael Strasser we're lucky to have on our board of directors. She is a senior director of ICAP at Columbia University's Mailman School of Public Health in New York. And Professor Peter Berman, we're lucky to have on our board, is an economist and a public health expert. He is an emeritus professor at the Harvard's Chan School of Public Health, and we're very lucky to have Peter on this panel. So with that, we're going to have short interventions by all of the panelists on how we can move forward and what interventions can be done to make global health more effective. And then we're going to have a short discussion amongst us. And then importantly, we're going to leave lots of time over to you to come to the mic. Please make some short interventions and tell us how global health can be more effective in this very destabilized world that we're in right now. So with that, I'll turn it over to, first up will be Professor Gruskin, then followed by Dr. Susan Michael Strasser, Dr. Siwan-Kambo, and then Professor Berman. Sophia.
Thank you, and thank you for being asked to participate in the conversation. And I think I wanted to start by saying that we're universities doing global health. That means we're getting hit from all sides, right? We're really at the crosshairs here, right? Universities and global health together. So in terms of feeling the effects that we're feeling wherever we're based, we're all experiencing it. And I really want to come back to, Keith, something you said. The sense of solidarity I felt here has been really helpful. And it's something that I haven't felt since January 20th. So I really appreciate this. I mean, we have been shown in record time the power that existing and incoming politicians in the US, but I want to be clear, not only in the US, hold to shape the laws, policies, and norms that impact global health. but it's the outsized financial power of the United States and the visible blows to global health that have happened since January 20th that is a threat that has to be reckoned with. Now, in this last week, both here and more broadly, I've been in pretty much the same conversations over and over again, and as I assume you all have. And I just thought I would summarize a bit about some of the comments that have come out of those conversations, because I think we are all struggling together in terms of thinking about how to think about this. And I think one point that was really made that was important is that, you know, despite the executive actions and the confusion and the panic that has swept through the field, there has been multiple court challenges, there have been multiple pressure campaigns, and humanitarian appeals to unfreeze aid. All of that shows that action is possible, and it's something we can't forget. But there's also been the losses of livelihoods, the basics of people dependent on the US government for food, for HIV treatment, and for their jobs. And, you know, the fact is that health has always been political. It's just that it's never been this bad or this stark, and the very real harms that are caused. So one of the things about now is this constant barrage, and it's about keeping pace with this change and everything that's going. And especially in a system, and I think this is, again, one of those things that seem very different, changes that are happening with what seem to be no concern with the impacts these are going to have on mortality, let alone on the mental health or physical health of people and communities. And we do have to get used to this level of uncertainty, as I suspect, at least for those of us in the United States, as long as our democratic institutions hold up. And I hate to say this, but it's an if to me at this point. But all of this is going to trudge glacially through the courts. So uncertainty is going to reign for a long time. But that said, just to take the US withdrawal or threat of withdrawal from the World Health Organization, it's starting to make much more explicit the fragility of global health governance. The fact that we don't have the scaffolding in place in ways that we have not yet addressed. The shock of one country doing this should not shake the system to its core in the way that it has. And that is something for all of us in all parts of the world we need to think about. So we need to figure this out as it evolves. So I guess the first point is the Albert Einstein quote, "Every crisis is an opportunity." I think right now it's a great crisis, so it's a great opportunity, right? But we all need to tread our own line in what it means to be both principled and pragmatic. And that means, at least for me, not making this about Trump and about the ongoing parade of horrors, but about the possibilities that this can open up for what can be possible in a system that, if we're honest, was already shaky, if not broken. And I mean that for both of us, those in the US, but also those of us who care and work in global health in whatever part of the world. So it's to be super clear that even as things change, it's okay to wait and go with the flow, but we have to be clear internally what are our own non-negotiables. I'll give you two for me. One is that for those of us from the US or voting in the US, separation of powers and functioning democratic systems, transparency, and that public health decision-making be based on data and evidence, not on opinion or whatever, right? And that includes accounting for the impacts of what's done once decisions are made across population health in publicly transparent ways. These are basic principles of good governance and public health that, for me, are non-negotiable. For me and other is the way that evidence has shown us time and again that we all have not only a right to the highest attainable standard of health, and I don't mean that in an abstract rhetorical sense, but that a rights-based framing offers something that is necessary for assuring the health and well-being of all people. And this means, for me, the need to double down on attention to disparities and to equity, no matter what words we're forced to use, and to the importance of a functioning civil society in order to engage with the health and well-being of all those who are most vulnerable, but also to hold our governments to account for what they do and don't do in the name of or with impacts on health and well-being. The last point I'd like to make, if I can just have a few more minutes here, is I want to call out our different vantage points at CUGH. Because even as universities and people concerned, we're all in this together, we're very different. Yes, as people, in terms of our nationalities and where we live and work and our disciplinary backgrounds, but also as students or faculty or administrators. All of the different kinds of roles we play and different types of academic institutions we represent allow us to think differently about what it means for how we can react and what it is that we must do. And so for those of us within the US, it's to be able to think about what it means to be engaging as a university, whether we are in a red state or in a blue state, a public institution, a private institution. For universities outside the US, how do you deal with us now? Right? How do all of us engage with governments, with regional or UN organizations, with civil society, with our program beneficiaries, with journalists? Who are the trusted voices that we can work with seems to me more and more important in terms of this moment. And CUGH has been founded on this notion of equitable partnerships. That's been foundational, I think, to how all of us want to do our work in global health. How do we think about equitable partnerships in this current moment? And so just the last thing I want to say about this is that in this current moment of attack on health and on the tools of public health and on multilateralism and on universities, it feels really important that universities come together to collectively counter the attacks on science. Many within our institutions were quiet when the discussion was about DEI and about gender, but became much more vocal when their indirect costs were under threat. We have to collectively decide how to respond so as not to sacrifice the few institutions or individuals that have chosen to be vocal. And I understand that what I'm saying is easier said than done, but we need to think about that collectively. And for our universities in the US, we have to be clear that even if global health isn't a priority in their struggles, it is very much for us of direct concern to everyone in this room. And for universities in the global south that deal with US monies, many rely on NIH funding coming through US partners, received on their own. There's also the very real impacts. A colleague in Kenya was telling me last week that approximately 35,000 people have lost their jobs in the last month due to the US government's actions despite the ruling. But most institutions, most small organizations are unwilling to start or restart programs. Everybody's scared. So wherever it is that we're based, I also want to call out the importance of our civil society partners and recognizing how much this is affecting our partner organizations so that we can try to work together. Universities are part of a global health ecosystem. We are not the ecosystem, right? And so we have to think about what are our different roles moving forward. The tactic, from my perspective, seems to be to isolate us, to isolate institutions, to isolate countries, to bully. And we can have strength in numbers. And I think CUGH is very well placed to help us coordinate this. Our institutions have to survive for us to be able to keep fighting for any of this. And I'll stop there. Thanks.
I guess I'll follow and use the podium. Thank you to our first speaker for kicking us off. I want to start first. I've been asked to talk about what this all means for training and education, which is my wheelhouse, and research around training and education. But I want to first stop and pause, given all that is happening, but reflect. I've been doing a lot of personal reflection, and thank you, Azali, for your very truth to power comments and making us all think what global health has and should be. But I want to go back to what I'm most proud of is being a nurse. And I started my nursing career in 1986. And what I learned about HIV at that time was that it's a new disease, we don't know what causes it, and there's no cure. And then I moved to work in a hospital in Colorado as a nurse where we were asked as nurses, would you be willing to take care of this patient? Then about a year and a half later, I moved to Zimbabwe, where by the second year that I was there, the entire hospital was people dying of HIV. And now, many, many years later, we are so close to epidemic control. We have had the privilege to develop and complete population health impact studies, impact assessments, FIAs, in many, many countries. And there are many countries that have done the unimaginable. They have reached epidemic control, which means 95% of people know their HIV diagnosis, 95% of them are on treatment, and 95% of them are virally suppressed. This is what UNAIDS and the prevailing scientists believe will allow us to achieve epidemic control. We are so close in so many countries. We have better HIV indicators along the 95-95 continuum in Africa than many parts of the southern United States. That should give us pause to the global challenge to health. And what is happening now as a nurse, I took an oath, I believe in my soul to do no harm. And what I most want to implore to say is we have a moral imperative, we have an ethical obligation to ensure that lifeline of antiretrovirals continues, to treat people and to prevent mother-to-child transmission, transmission between discordant couples, and to all people at risk of HIV infection. But I'll pivot from that. That's my personal just statement I wanted to start with. I've been asked to talk about what this means for education, pre-service training, on-the-job training, and research. Just a few things. We need to accelerate the use of competency-based education. We need to educate on the need to know, not just the nice to know. Many educational systems are very theoretical, and people get out into the health workforce, and it takes them a few years to really get their wings to be able to work effectively. We need to increase the use of simulation, and I've seen in places like Sierra Leone and Zambia, where resources are not tremendous, but they have done incredibly innovative things with simulation, using their own tools, their own, not fancy machines or high fidelity simulation, but using their own tools to allow students to practice in ways that simulate the real world. We need to find economies of scale. We don't have time to continue to reinvent the wheel. And there is a global equality happening in education through the power of the internet. We now have platforms that are open source that have high quality public health, medical, and nursing education. Lecturio is one. Scholar RX, and we have representatives here from that, is another. And many, many organizations make their educational materials freely available online. And institutions need to capitalize on and utilize those and not reinvent the wheel of writing their own curricula. They need to take that time, that energy, and the resources of professors to practice what it means to be boots on the ground providing health care. As we are challenged to deal with emerging infectious and re-emerging infectious diseases, as well as the aging population globally and the rise of non-communicable diseases. We need to be critically reflective of what the health workforce needs to be able to do in the 21st century, what it will take to be effective, cost-effective, and effective from a high-quality care perspective. We need to emphasize South-to-South exchanges. There's tremendous resources in the global South that need to rise up as the leaders, and we see, for example, AfriHealth and other leaders. I don't know Asia as well as I know African institutions that are very, very strong, but I'm sure in many countries, utilizing those resources and having those South-to-South exchanges is very, very important. We need to increasingly use interprofessional education and remove the silos, the hierarchies, to allow us to come together. And this is most importantly true in One Health, in the climate crisis, in the intersection of animal, human, and environmental health. We all need to be working together, but also training together, learning together. The challenge and the changing landscape requires intensive innovation and local investment. Often we have come in, as has been said, the savior, and local investment needs to be prioritized, and local advocacy for the return on investment in human resources for health. I had the opportunity to lead the Nursing Education Partnership Initiative, which was an 8-year program across 10 countries, including nursing councils, nursing associations, and nursing schools. And that was a tremendous investment in the health workforce. But I had the hard reality thrust upon me when I realized in Lesotho we had worked with every school of nursing in that country and dramatically increased the number of health workers that were trained and ready to enter the workforce. And we were getting flack from our donor to make sure that they are absorbed into the workforce. And that was really out of our control. And I talked to the Minister of Health, and he said, Susan, I would love to take every one of those nurses. We need, we want, and we must have those nurses. But we have our hands tied because of global loans that require us to limit the number of people in the public sector. So those nurses are sitting highly trained, but not able to be absorbed into the workforce. So I also learned from a colleague in the World Bank, he says, it's important to, of course, work with ministries of health, but the people you need to speak to are the finance minister, the Department of Defense, and make the case why the return on investment, not only in the health workforce, but in a healthy population, is imperative to a thriving economy and to a strong nation, a secure nation. And lastly, I'll just talk about research. We need to talk about the full scopes of practice for all health workers. We've often talked about task shifting, but nurses have long done a lot of the work that is, we think, more of for physicians, because in the majority of places, it's nurses that are providing the primary health care in the world. We need to do research on what it truly means to empower communities and put the power in their hands. We saw tremendous potential when in West Africa, the Ebola outbreak became out of control, and there was the development of what are called community care centers. Those were developed and run by the community. And they did tremendous work to help stop the Ebola outbreak from spreading further. We need to have research to combat misinformation. We, as health workers and as experts, need to learn to sit down with people who disagree from us and listen to them, listen to their fears, listen to why they believe what they believe, that is allowing a measles outbreak in Texas right now. Why this is happening. People are acting not, we may think irrationally, but this is coming from a deep-seated belief, and we need to better understand and learn how to listen and how to communicate with them so that we can help them to see that vaccines are one of the best, most amazing public health innovations of the 20th century. We need to do greater research on what we can do with less to provide high-quality health care. And I'll end there by saying we need to get back to Alma Ata. We need to get back to primary health care. This is what, in my core of my being, I believe in most, what it takes to keep a society healthy. And that is good, clean water, good nutrition, good primary education, education for women, and basic access to primary health care, immunizations, well baby visits, growth monitoring, oral rehydration, maternal health, routine monitoring of mother's health, and care for episodic conditions, and using basic parameters to treat chronic conditions. And I just, for the young people in the audience, if you don't know Alma Ata, I would encourage you to learn as much as you can about the beginnings of the idea of primary health care, and really embrace that as the bedrock of the world's health. And if we had better primary health care in the United States, the country that spends the most healthcare dollars of anyone in the world, but we have syphilis, congenital syphilis. We have rising maternal mortality rate. We see tremendous disparity in social determinants of health. COVID showed us in the United States how glaring the social determinants of health are and how disparate life expectancy and the risk of COVID-19 was people into the United States. And that's not because we have beautiful hospitals that can do triple bypass heart surgery. It's because we don't invest in primary health care. Thank you.
We have had a lot this morning, things which are very stimulating and provoking. I have a lot to say, but of course time is limited. Let me first comment on the Consortium of Universities for Global Health. I was fortunate enough that when this consortium was starting, I was there. And university presidents from the US, from very prestigious schools, gathered together and endorsed the idea of Consortium of Universities for Global Health. Now, the discussions and presentations that take place at this meeting are very informative. But I have often thought that this is North America, in fact, not North America, but largely US institutions talking to themselves. And yet, we are saying that global health affects not only, or is important, not just for the US, but for the world. And therefore, the consortium, CUGH, needs to reflect further on how it can really have a global impact in terms of global health. Membership, first of all, how are there many universities across the world in low and middle income countries that are members here? How do we make sure that indeed there are more members from the low and middle income countries joining CUGH? Not only joining CUGH, but actually coming to these fora to participate and benefit from the rich discussions that take place. I'm fully aware that CUGH has or started thinking about rotating these conferences. I'm not yet in the know of whether the next conference in a year or 2 or 3 will not be in the United States, but will be elsewhere in a country like Uganda, where I come from, or Latin America, or Asia. This is a very important issue if CUGH is to reach far and wide. The cost of coming to these meetings is a deterrent, of course, and therefore we need again to think, how do we make it possible for more people from those countries to attend the meetings? The rotation, of course, would be one thing, but we need to think beyond that. And so when we come here, then you find that there are, just a few people from LMICs. And yet, we should have many more participating in the discussions and bringing real experience on the ground of the things they see and feel on a day-to-day basis as they conduct their work. let me move on. The recent events in the United States have shocked, have surprised many of us. But I think there's an opportunity here. There is a real opportunity for us to deeply reflect and say, this should not, what we are going through or the potential impact of these events should not be allowed to happen again. How can we do that? Or let's ask ourselves the first questions. For example, when there was the stop work after the president declared his executive orders, people in LMICs who are affected a lot, there was fear for what next. The question, big question, is American support has been into these countries for a long time. How come that there was no inbuilt mechanisms for sustainability? And sustainability has been talked about quite a bit this morning, starting from the lecture we had first. How come that programs were started and either there are no sustainability mechanisms included right from the beginning, or if there was an attempt, they didn't work? So deep reflection now needs to happen, particularly in the LMICs, and say to themselves, should not find ourselves in the situation into the future. How do we avoid it? Of course, it is going to be difficult to make significant changes in a short time. But this gives us opportunity to have determination and say, we need to have sustainability mechanisms moving forward, and also our governments, our countries must deeply reflect and allocate resources that are required increasingly so that we can do things that we would like to do and things that we think are priorities. We, the previous speaker, talked about AfriHealth, the African Forum for Research and Education in Health in Africa, a forum that was started so that it could bring together African institutions across the entire continent. Of course, it is an ambitious project, but to bring together institutions, and therefore becomes a very good platform for which to discuss, learn from each other, and determine on how we move forward. What we've noticed so far, there are some very good partners who have stepped up and said, we shall collaborate with AfriHealth. But many others decide to do things sidestepping the African Forum. And yet, we do not dictate on how we work, but we discuss amicably with our partners. I think those are the kind of fora that would be very important in taking forward global health. There may be fora in Latin America, there may be fora in Asia, which we should, as CUGH, work very closely together and be able to make a dent or to move the needle faster than we would have done. Regarding these conferences, it's not easy, but let me suggest it, that CUGH could find a mechanism of asking people around the world as to what can we focus on 2 years from now, so that there is a time lag that allows us to prepare, consult stakeholders, and say, yes, the people are saying this, and we should focus on that in 2 years' time or 3 years' time. Lastly, 2 points. We had a lot governance emphasized this morning, and we should make sure in global health at every step, and in whichever we do, we think about governance and governance mechanisms. Starting, of course, with the governance of CUGH itself. Because we need to become role models as CUGH and practice what we want people, or what we want to recommend to people as the best way of doing global health. Lastly, again, the recent events emphasized to us the importance of engaging politicians. In this room, if I asked how many here are politicians, I would be surprised if we get a handful. How can we come and discuss just as academics, largely, and leaving out that very important group to also learn and hear and share the ideas that are exchanged here? My plea, therefore, is that we should invite politicians, policymakers, to be in our midst and become very important vehicles or contributors to what is discussed. Thank you for your audience.
Good afternoon, everyone, and thank you for the opportunity to join you in this meeting. As the economist on the stage, of course, I think I'm going to speak a bit about resources and finances. But let me start recollecting economics is often known as the dismal science. And that name was given because of the fundamental human condition that our wants and needs often exceed the means that we have to satisfy them, requiring us to confront that fundamental condition of overall scarcity and the challenges of making decisions in that situation. And I think that's very relevant for us to keep in mind today. I began my journey in global health a little more than 50 years ago. I was inspired as a young person by the challenge of the huge inequalities and disparities in the world that I could observe as a student. And I thought, this is the challenge that I wanted to devote myself to, and that was the challenge of my generation. I sometimes tell my students that at that moment, I thought if I were ever standing up in front of a group like this more than 50 years later, we would have solved those problems. Unfortunately, that's not the case. So this is now the challenge for the next generation. But it's important to keep that in mind, that these are deep and difficult problems. It's also important to keep in mind that in many ways, the world has made more progress in reducing the inequalities and the disparities in health in the last 50 years than it has made in centuries preceding that. The problems still remain, but we should feel a sense of optimism as well at what has been accomplished and what could still be accomplished in the coming decades. So I wanted to start with both of those observations. Now, to turn more to the finance and economic side, we are all shocked by the events of the last few weeks in terms of the United States reductions or suspensions of the financial support that we have been giving to global health around the world. But I want to also have us be aware that this in itself, while it is part of the financing crisis facing global health, it is not the only part, and in some ways it's not the main part. We have already been experiencing a significant global financial economic stress since the pandemic started in the year 2020. And some of that global financing stress is seen today in the rising debt levels of countries across the world, high-income countries, middle-income countries, and lower-income countries, although the debt stresses on the lower-income countries are much more severe. And we have seen the fall-off in global support for global health, not only from the United States, but from other countries. So let's indeed focus on the things that, for example, myself as an American can potentially influence, but let's not see that as the only problem we have to confront today in re-energizing and resuming the tremendous progress towards global health. The U.S. is a significant funder of global health activities, but it is not funding all or most of the global health activities. We need to keep in mind that it is the governments and the citizens of the countries themselves that are supporting health activities in their countries. And this should give us a sense of also opportunity, that there is more out there than just the United States. I'm not saying that we shouldn't resume in the United States our support for this global need, but I think we should keep in mind that we are only one part of a larger picture. Another thing I wanted to mention is that for the global support to the lower and middle income countries' health efforts, we rely on the commitment and interest of the citizens of the countries that provide this support. And I think we need to reflect ourselves at how we perhaps have not been sufficiently active and sufficiently successful in persuading the citizens of our own country, the United States, and other high-income countries of the value of these contributions and the need and the opportunity they have to make a difference. We have seen surprising events in the United States where our government, reflecting the will of the citizens, has come forward with significant assistance. And I think the PEPFAR program is an excellent example of that, of almost 20 some odd years ago, 25 years ago. But have we sustained, those of us who are in this field and in this world, have we sustained our commitment to keeping the rest of our citizens engaged and committed in this area? I think we have to reflect on ourselves and say we could do more and we could do better in that regard. And that could help us as well. And I think this is not only true in the United States, this is true also in other high-income countries, where we have seen some falling back and reduction in commitments to global development and reducing global inequality as well as global health. So I think I'm going to stop with those introductory comments. I think we'll have some time in the conversation to talk about what to do. Number of people at the meeting this weekend have emphasized, and I think Professor Siwankambo also reminds us, that it is ultimately going to be necessary, essential, to get greater participation, contribution, engagement from the citizens and governments of the countries where the need is greatest. Their capacities are constrained, indeed, drastically constrained. And this is a very serious problem we must acknowledge and try to address. But also, I think this may be a turning point for them to also recognize the need to take greater authority and responsibility and direction in the future. So thanks very much.
Thank you very much. Thank you very much to our wonderful panelists for a start. We'd like to get your input and your guidance. That was the primary reason for this plenary. So I'm just going to ask one question to all of our panelists. And please, while we're doing that, for some sharp answers, we're going to turn it over to you very quickly. So please, if you have some questions, go behind the mics. Please limit your questions to a minute because we'll finish at the top of the hour, and we'll get through as many of your questions as possible. If you limit them to 1 minute, our speakers will limit them to a minute, and then we'll be able to have a very, very rich discussion. So the one question I have for all of us is a nice segue from what Peter challenged us to do is, what are we going to do? So I'll start with Professor Siwankambo on this side, and we'll move across. What is the one thing that you think that our institutions, members, or CUGH can do to be able to address this new normal that we're in today? If you had one wish, that practical, concrete solution of what we can do, what would that be? Nelson.
One thing I would advocate for, that we, in our individual countries and institutions, we become much more active and engaged in talking to our policymakers and politicians, that they take on these issues and the countries have greater control in moving forward along the global health issues.
Thank you, Nelson. That's really critically important that we speak to the politicians as you challenged us to do. Susan, please.
Yeah, I think for us, the challenge is to, and this is very granular, is how close we are to achieving epidemic control and why staying in is in our best interest as a country. And as we do transition, which has to happen and has happened in many cases. I work in many countries. We're in over 40 countries, and in Zambia, we have successfully transitioned a number of provinces that are completely led and managed to a very, very high level by the districts and by the provinces. The biggest challenge, and I think most of the HIV expertise in the world is in these countries, much more than in the United States. The expertise is there, the health workers are there, they have to be paid to continue. The biggest challenge is the drug supply. So I think, imploring that we are very close, and that while transition is very important, that transition should be measured and done thoughtfully and carefully to not reverse the tremendous gains on how close we are to epidemic control.
And I would encourage folks to really look at ICAP's work that Susan helps to lead. It's really a jaw-dropping example of an excellent program, so please.
Sure, and I'm going to intrude a little bit on Peter's space. for a moment, and we'll see. But I think I want to talk about economics for a moment. You know, I think one of the things that is to be able to support countries in terms of figuring out alternatives to this dependence on U.S. money, right? But then the issue is, and it's very much in line with, I think, in terms of kind of what you were talking about, the issue is, you know, turning to domestic funds or other international funders in terms of what that means in terms of filling the gap. And, you know, we think about Brazil, India, South Africa, you know, kind of others who are playing in this space. And, you know, Brazil is holding this summit in July, right, which is about global governance reform and global South cooperation. And that feels like an opportunity in terms of actually being able to think about what can be supported in terms of being able to happen, what happens within countries. But I want to come back to why I think the multilateral system is so important and not losing sight of that. And what I'm really concerned about is as we have these conversations, is there is some level of nationalistic component anytime we're funding only our own. And one of the things that I think is really helpful about a multilateral system is it recognizes that problems are global and that we need global solutions and what people have to offer from all places. So where do we go, is not to just retreat back into our own spaces, but to reach out and to continue to being able to reach out.
One, and that's really hard. I would say I think we need to work with our partners in the rest of the world, both the expert partners, the economists and political scientists and other thought leaders, but also the citizens groups to move their governments to sustain the gains that have been achieved so far as a minimum in this moment of difficulty. And then to set practical priorities for moving forward from that space.
Fantastic. Thank you. What a great job. One each. What a tough question and wonderful answers. So what we'll do is if everybody can limit their intervention to a minute, please. We'll go through the first individuals at all three mics. We've got very full mics right now. And we'll start with Dr. Roger Glass. Roger, thank you for being here. The former director of the Fogarty International Institute. Dr. Glass, thank you very much for being here today. And then we'll go for each of you, and then 1 minute, please. Thank you.
Sure. In 2009, when CUGH was formed, there were 7 U.S. universities that came, and there was not a lot of global health on U.S. campuses. We were a very insular country. And what's happened is that we've really now, 15 years later, have global health on so many campuses and such interest. So, and I think much of that was funded and supported by the PEPFAR program and the great funding. We activated AFRI Health with a grant, and that's been a terrific coming together. I've been to many of these regional meetings like the PMAC meeting in Thailand, which brings together leaders. And I do see a global need to bring universities together for this. And this is a great way to start, but I have to see how CUGH can mobilize these in the other areas. And I think that's going to be a real challenge, a strategy session that has to happen. But this has been an incredible meeting, and the fact that there are so many internationals here is a reason to think further. Thanks so much, Keith. This has been an incredible meeting to all of you.
Thank you for being here, Roger. Please.
Hi, I'm Tara Casebolt from Loyola University Chicago. I'm an assistant professor. Quick comment, then a question. My comment was just, I work in reproductive health. I'm a lot less shocked and off guard by this than a lot of my colleagues. I think prepping for the global gag rule every 4 years has really prepped a lot of people in repro health for this kind of thing. So maybe talk to your repro health colleagues about how they cope. But I think for dealing with this going forward, we have shown now the US government is no longer a trustworthy trustworthy or reliable partner around the world for governments, for organizations, and a lot of universities and large U.S. institutions get their funding from U.S. government funding, and so that's going to make us seem untrustworthy and unreliable as well. So I want to know what CUGH is thinking about doing or could do to try to maintain those relationships, to try to keep that trust from eroding, and to try to rebuild it as we go forward, because this is not just the next 4 years. This is going to be a long-term problem.
Thank you very much. And the last question, we'll go to the answers. Thank you.
Hi, my name is Heidi van Rooyen. I'm an immigrant, South African in Seattle. I joined the 1st of October. So first, it's my first CUGH, and to say thank you to all of you. It has given me a sense of community. I want to make 2 more critical comments. And the first is to kind of emphasize some of the points that have already been made from the podium. And it's around the fact that I think this is not just a reckoning for global health, it's a reckoning for CUGH. It's a reckoning, I think, along several lines. I think there has been talk about a re-looking at strategy, and I don't think it's just strategy. It's something about how does CUGH in this moment organize itself differently in a way that addresses some of the issues around membership, around voice, around representation, on its committees, on its board, on its structure. Because if it doesn't fundamentally shift some of that, it will remain a really wonderful consortium for those of us who work in the North to engage with each other about the good work we are doing in the Global South. And I think that's the reckoning, the shifting and the recognition that you are in a really, really powerful and unique position to be holding this moment for all of us really differently. And the second point relates to the first. And it's my plea and my hope that as we are all as kind of global health researchers, chairs, practitioners thinking about what this reckoning and reimagining is about, I would hope that CUGH can hold that bigger conversation. So not just business as usual, another annual meeting that looks at global health, but in this year and in the years ahead, to really, really hold this big fundamental question about what is global health right now? What is this reckoning? What is this reimagining? What is this moment? To convene this bigger conversation. I feel it would be incredible if you could do that. Thank you.
Thank you. Thank you very much for your questions, everybody. So let's turn to our panel. Dr. Glass was talking about how do we mobilize more effectively, how do we keep our relationships going, particularly in the face of an assault on reproductive rights that's certainly coming. And then finally, the reorganization of CUGH and how we can be more diverse. Anybody want to take any of those?
So just a thought in relation to the last comment. I do think that we need to recognize that CUGH, by virtue of its name and organization, is about working with universities. And universities can play very significant and even more significant roles in the countries where they are located, and we should be making great efforts through CUGH to strengthen those universities to be the sources of knowledge, training, and influence in their own countries.
Yes. Okay. So I want to just add 2 points. One was in terms of the question around haven't we learned in terms of what the assaults have been around reproductive rights? Yes, absolutely. And we've been following, all of us, I think, what's been going on. I think that what's important as an opportunity is to think about how this helps us now to connect with other colleagues who maybe weren't paying attention to what was happening around reproductive rights. And so I think about colleagues in the climate space, and I think about colleagues who are in the infectious disease space who were not necessarily as engaged in terms of being able to think about this. So I see that as a potential opportunity. And the other thing I want to raise that I think we haven't talked about yet is subnational actors, because it occurs to me that that's another piece of this that we really need to put on the table, which is, you know, in the Trump administration previously, one of the things that happened within the United States was the growth of strength at a subnational level in terms of what states and what major cities were doing. That's true in many other parts of the world as well. And I think in terms of thinking about CUGH, the question about subnational actors and how those subnational actors engage in global health is also potentially an opportunity to put on the table.
I wanted to get to the comment about trust. Trust is essential for any collaboration, and thank you for bringing that up. Yes, the U.S. is looked at very differently right now. I think we have to identify the ways that we can show that we are a trusted individual and we are a trusted collaborator, and we're not going anywhere. Our funding may not be to the extent and have as many zeros as it had in the past, but we still want to be engaged to make a healthier world. We still want to engage to work together, to learn from each other in the spirit of true partnership, and that, I think, will continue to build trust. And I believe by staying the course, by not going away when it's not as glamorous or as lucrative, that will build trust.
So for me, let me focus on the comment from the last speaker down the mic, who says CUGH should reconsider how it is organized, representation, and so forth. And I entirely agree with that suggestion. And that is what I actually also was referring to when I said we should think about governance more critically, even for CUGH itself, because then we become an example to others who want to go in this direction. I have been president of AfriHealth since September last year. And one of the things that I've been thinking about is this whole issue of representation and how do you encourage more participation of members from across the entire continent, not simply from a few clusters, but the entire continent. And I think that thinking also is similar to what we're suggesting for CUGH. So that there are people all over the place who are contributing to these discussions. We, of course, there are challenges in recruiting members from such a diverse community and so forth. But when I think about global health, it shouldn't be predominantly health people, those who consider themselves health people, physicians, nurses, pediatricians, and so forth. But we should be very attractive to having engineers whose work impacts on the health of the people. We should see a number of veterinarians in our midst because one, health is important. And the health of animals impacts the health of the people. So how do we make CUGH a much more representative forum, seeing or bringing in all those different types of people? And of course, going back to policymakers, that they should be here as well.
Thanks. And you know, this is your challenge to us is exactly what we're interested in doing. We would love to be more diverse. We're continually trying to do that. We need your help to make that happen. We need to work with subnational actors, folks in government, people who are in the biomedical field. This is a bit of an unusual panel because you have an economist, a lawyer, a nurse, and 2 physicians on this. But we definitely been trying it, and this is an area we'd love your help in and any connections you can make into the non-biomedical fields. Because we know we can't get the stuff done with just those of us in the biomedical field. We need lawyers and engineers and social scientists and economists in our field to help us to get the job done. You know, a lot of folks who are trying to come here couldn't come here because of circumstances, and we're sad about that. But I'm happy to tell you that there are 61 countries represented at CUGH 2025. 61 countries. We're very grateful, yeah. And we're particularly grateful to you who have come from afar to make that happen. So let's work together to have a greater diversity, greater international representation in everything we do. We would love to make that happen. So we'll go through another line of questioning, and a minute, please, each. We'll get through. Dr. Susskind. Thank you.
Yes, Bob Susskind, CUSM. Thank you, Keith, for putting together a wonderful program for these last 4 days. And I especially enjoyed today's. And one of the things that I think we might focus in on, because I've heard the importance of governance and getting the governments of our constituent countries involved, is limited by the loans that they are given. And so maybe what we ought to focus in on are the banking industry, to see if they can rewrite those contracts so that governments can then take on the responsibility of the programs that are not being funded by the U.S. government with the changes that are going on. So it may very well be that with The Economist on the platform, that you could provide the opportunity of how do the governments of each of these countries change the contracts so that they are able to fund the gap that is in there with the USAID being decimated.
Thank you very much, Dr. Susskind. Please, Sekou.
Thank you very much, Kate. Good afternoon, everyone. My name is Major Dr. Sheku Dennis Massakoy from Sierra Leone, West Africa. Mine is two. One is a question to Professor Tiwa Campbell, then open to all panelists to comment. The second one is a request to all those coming from the LMICs, mostly from Africa. I want us to see ourselves here as ambassadors for CUGH. When we go down, we don't work in isolation. Paraphrasing the quote from the session we had on global surgery, they say if you want to go fast, you go alone. If you want to go far, you go together. So I'm requesting that we go home, we ensure we work as a team collectively. A classical example is in my country, Sierra Leone, currently working with health economists, legal practitioners, the nursing practitioners, the community health workers in establishing the inaugural national social health insurance scheme in my country. And we started off by working a baseline assessment of all facilities. We ended up detecting that we have 1,635 health facilities. So what then did we move on to? We developed a digital tool, Kobo Collect, that we are going to assess all those facilities, see where they are doing well, where they are lacking, we advise, and then we collectively pool some amounts, give us capitation that are going to step up to ensure we have an effective healthcare system in Sierra Leone. Then we can propel that elsewhere. So moving forward, it's imperative on us, we don't escape from politics. We need to navigate around, work as team, see how we can propagate the agenda of CUGH. Now, my question is to Professor Tiwa Campbell. All others can comment. So now moving forward, looking at the backlash we are having now down there because of this current situation around, the decision and the likes. So do we really think that having an effective national social health insurance scheme in our countries down there could be of help in mitigating some of this shock that we are having now because of the current situation in America? That's all I have. Thank you.
Thank you, Dr. Massakoy. And what we're going to do is just end the questions for everybody who's here right now. So I'm just going to go through, thanks, Dr. Susskind, and then we'll go to Dr. Elsie Kukujuli Malawadi, Dr. Nguria, and then the last three people there will be it. But we'll do everybody's question at once, and then the panel will answer. Please, Elsie, thank you.
Thank you, Keith. This has been a wonderful conference. And I'm Elsie Kukujuli Malawadi. I'm the former president of the African Forum for Research and Education in Health. And I would like to pick on the point that Susan emphasized about South to South collaboration. There's immense capacity in the South, but many times we don't utilize it. And many times we look to the North for capacity building. And even after we get that capacity building, we don't share it. So it's not a question, but an appeal, is that maybe is there a way that CUGH can help us to share this knowledge, the capacity that is built in the South, between the South to South collaboration? We are trying through AfriHealth, but it's not enough. So if organizations like AfriHealth are supported to share across the South, I think it would really go a long way to improve that. I mean, I've been here and I've had a lot of good work that is happening in Uganda that I never get to know about when I'm back home. Thank you.
Thank you very much, Dr. Elsie Kukujuli Malawadi. He was the former president of AfriHealth. Thank you, Elsie. Dr. Nguria.
Thanks so much, Keith, and to all the panelists. My name is Christine Garuya. I'm an associate professor at a university I'm not going to mention, and an adjunct at another university I'm not going to also mention, because this is a bit of a personal plea that maybe reflects others in the room. So I'm an associate professor, someone who's come up the ranks, happens to be a Kenyan diasporan, and done it, I think, using my platform in sometimes a very radical way, some might even say. And so this is both a personal plea, but also a plea to CUGH. How we allow ourselves to go out as individuals and be able to do this, be radical, and continue to step up to our universities to say they cannot back down with how we're doing our MOUs, how we're establishing our partnerships, in fear of what our governments may be saying about funding, and still protect folks. And it's a personal plea because I do have said things in spaces with fear, genuinely, to be vulnerable. I look at who stood up and spoke at the microphone. There are not a lot of very young people. There's a student who spoke up, right? How do we protect that student and make sure that she continues to use her voice? So it's a plea to the very senior folks in our in the room. It's a plea back to CUGH. I don't know if we create mentorship sessions over the next few years, if we have some indexes of databases of language people should be using and other strategies, but I think it's so critical that we, out of this choir, we go to our places and still feel safe to speak up and really have action over the next few years.
Thank you very much, Christine. We'll finish the last three questions and then we'll go to our panel. Thank you.
Good afternoon. My name is Dr. Calais Philippe from the Bahamas, Ministry of Health and Wellness. So I'm one of few people from a ministry, as well as from Earth Medic and Earth Nurse. I want to thank the committee and want to thank Dr. Saria Hassan for the panelists that she put together across the world on climate change and NCDs. As I've listened to the panelists, I reflect again on the definition of global health and recognize that we need to be addressing low resource settings. And so may I suggest that by recruiting members from countries with low resource settings in terms of universities, so there's a University of the Bahamas, there's university in Haiti, there's university in other countries that are not represented here, particularly the small island developing states, the Pacific. So if you are going to expand to be really global, then you need to identify where you are not recognized. So this is the first time I've been to this meeting. I've been in medicine over 30 years. I'm ready to retire, and the first time hearing about CUGH. That should not happen. But I'm sure there are many of my colleagues around the world who do not know about your great work that you're doing and would like to be a part. I think also adjusting the membership fees as you talk about the economy. If you are trying to reach low resource settings, then you should consider adjusting the fees, the registration fees When we applied, the recognition is, I'm coming from a country of the top 10 that is impacted by climate change, and yet my country is seen as a high-income country. Therefore, your registration fees biases, discriminates, despite my having the impact of climate change over the years, right? And then looking at populations that are smaller. So countries here are like 100 million, 40 million. The Bahamas is 400,000 people. And there are even countries with smaller populations. Also, the community engagement component, which CUGH in universities are calling about community participation, research, those people should be represented. There should be a panelist of experts in community engagement who share what they think. Thank you so much.
Thank you, Dr. Kelly Phillip. Thank you very much. We'd love to have more small island states involved in CUGH, and maybe after this we can chat if that's okay. Thank you. Please.
Hello, my name is Fuji Su, and as a background, I'm trained as an infectious disease physician and epidemiologist. And growing this in my professional life has been saying that want to be global citizens because microbes doesn't care about the borders between countries. But we keep discussing the countries, and I watched painfully about the lack of agreement in discussing a negotiation for the pandemic agreement or treaty in the last year or two. So I think this is the moment for reimagine everything and rethink everything. So I went to the Carter Center during this trip, and what touched me was that song played again at his funeral, which is Reimagine There's No Countries. And how we do that? Imagine, because we are living in the fragmented world, and I'm an immigrant to the US, so I cast the vote in the blue city of Decatur nearby here, but in the red state of Georgia. Given that it's now so polarized, right? So it's no representativeness in any government in this country right now. And I wonder, globally there's a lot of, a lot of different ideas are competing with each other. There's a lot of anger, a lot of conflicts. So for this CUGH, this is the representative supposedly of all the ideas. Something about imagining there's no countries, maybe give us some freedom to think about the future. Thank you.
Thank you very much. Please.
Thank you. My name is Andrew Johnston. I'm the Director of Medical Oxygen Training at Build Health International. We're a NGO that focuses on health infrastructure, so architecture, engineering, and construction. I was thrilled to hear the panel mention engineering and that biomedical engineers and technicians should be in this space. I've been focused on the medical oxygen scale-up for the past 3 years, and what I'm seeing and why I focus on the training piece is that investment in machines is very important, but investment in people, both in terms of skills training, but also in strengthening the management systems and strengthening the relationships between biomedical technicians and doctors and nurses is essential to keeping medical equipment going, which is going to be a fundamental thing to raise the quality of care in a lot of contexts going forward. And so I just want to emphasize how thrilled I am that engineering came up. I came to this conference in part because of the Lancet report on medical oxygen that recently came up, and just to emphasize, one thing that the past 3 years of work in medical oxygen has shown us is how important it is for doctors, nurses, and other public health practitioners to partner with engineering and biomedical technicians. Thank you.
Thank you very much, Andrew. And we cannot do our job without you, 100%. We look forward, let's connect, and we want to work with you to get more engineers. And I certainly draw attention to your really outstanding Lancet Global Health report on access to oxygen security. It is really superb and life-saving. So congratulations to yourself and all the team, including Zoe Mullen, the editor. Well done. So we'll go through the questions. So we had started with Dr. Suskind, who was talking about it really increasing fiscal space and debt restructuring. We'll perhaps give that certainly to Professor Berman. And then the second question was to Dr. Masakwai, and he spoke to, this question is for you, Dr. Siwan Kambo. And then the next question was on South-South collaboration for Dr. Michael Strasser. And then we had a question on how to increase the space to be more effective and be able as students and others to be able to speak in academic institutions. Maybe Sophia, you want to take that on, and anything else we missed. So we'll start in this direction then. Peter?
Okay, thank you. So I think I will just briefly say that I do think that the international finance institutions are trying to step up and alleviate some of the stresses that many countries are experiencing. But we have to acknowledge that even if banks renegotiate their contracts, they still want to be repaid if they're making loans. And I would emphasize that this means that we do have to balance urgent health needs with the need for creating economic growth, and that we are in a world where the private sector is an increasingly important part of economies, and there could be more contribution from that side in many countries. These are totally inadequate responses to a very difficult question, but I'm going to stop now.
I'm with you. So I'm going to take it in terms of actually just thinking about the where do we go from here issue, because I think one of the things we need to be thinking about is what are these shifts in foreign policy, U.S. and otherwise, how are they affecting the communities that we work with and that we're talking about? And I think we really need to be thinking about where are the resources to be able to understand what's happening, and even more importantly, to be able to ensure that the interventions that people need are not lost, right, in this moment where the resources are going. So how are we going to do this? How are we going to hold ourselves accountable to that is, I think, a really crucial issue of the day. And I hear it, I mean, it's not directly responding to any question, but I kind of heard it throughout. And I also wanted to say something about education here, which is that I think that that all of us are in some way or another educators in global health at the universities and the institutions that we represent. And it goes to the comment about engineering, but even more so, which is that I think we are not training our students adequately for the world that we're in now. And that we really need to be thinking really clearly about how is it for students that are in medicine or in public health, how is it that we are teaching them to make the links to engineering and to law and to policy and to those things that are directly impacting the work that we do. And my hope is that one of the things we can do through CUGH by bringing people together is also talk about what this can mean for moving an educational curricula forward.
Thanks. To Elsie's comment, I would just say I completely agree. I mean, there are experts throughout Africa, especially in the space of HIV, that are the best in the world now in advanced HIV disease, drug resistance, et cetera. I think more and more recognizing the South-to-South experts and collaborating between them. You know, you're not an expert in your hometown. You're an expert for some strange reason when you get off an airplane. And I think we have to really get away from that. There's tremendous experts, clinical care experts, research experts in the Global South, and seeing them truly as the experts that they are. But Andrew, I'd love to talk with you. We've had some funding to collaborate with our engineering school and have a lot of ideas. So I'd love to speak with you afterwards quickly.
Yes, there was a direct question for me regarding health insurance. Absolutely. I think if we had national health insurances in our countries, we will be in a better place. An example that I can think of right away is Rwanda, which has done very well with the national health insurance up to this time. I don't remember the actual figures, but more than 90% of its population has national health insurance. And therefore, this is an area we should be striving to to make sure that in all these countries, LMICs, there's national health insurance. In my country, we've been discussing national health insurance. Papers have been written, reports have been written for the last more than 10 years. But that has not come to be yet. However, personally, I'm so convinced about national health insurance, or health insurance. 3-4 weeks ago, together with my colleagues, we had been planning on introducing a community health insurance scheme to the population where we are working. And so we went out to visit a district in the country which has got a community health insurance scheme. And it was very informative, and we are pushing ahead to go in that direction. Let me just comment on this South-to-South collaboration. It is something I love dearly. And South-to-South should engage or involve also in-country collaboration. Because institutions in one country, they may not talk to each other about collaboration. They look beyond the national boundaries. There should be collaboration on a continental level, for example, in Africa, collaborating, institutions on the continent, collaborating with others on the continent, and then going beyond to collaborate or partner with to partner with other low and middle income countries which are elsewhere. I was in Thailand a few weeks ago, and people there were excited to collaborate with us in Uganda or broadly in Africa. We should utilize this opportunity to actually do that in a very strong way.
Well, thank you very much to all of our panelists, Professor Peter Berman, Professor Sophia Gruskin, Dr. Susan Michael Strasser, and Dr. Nelson Siwan Kambo. I think before I turn it over to our Vice Chair, Dr. Olukunle Alonge, just to say that we have our work cut out for us, right? This is unlike any other moment in time that we've probably ever had in our lifetimes. As Paige Alexander said, the fundamental structure on getting stuff done are the structures of governance. And there is a fundamental assault on those structures taking place right now. As she said, we have to be bold to be able to address those. You know, Bertrand Russell said that at the beginning of a dictatorship, one of the first things that happen is to muzzle academia. We cannot allow that to happen. And I know it's difficult, as Christine said, for individuals to work, but we're going to work with you. We're going to provide the guidance that may be useful, that hopefully is useful to you, to being able to speak out. Because if we don't speak out, we'll be steamrolled over. And the consequences to those who are most vulnerable in our world are catastrophic, more so than any of us who live in privileged environments. So we at CUGH look forward to working with you over the next year. We look forward to coming together with you in Washington, D.C. next April. In 2027, we will be outside North America, as was suggested to us. So the board is working to make that happen, and we're pretty close to making that happen. And with that, it's a real privilege to turn it over to close our conference to our new Vice Chair, Dr. Olukunle Alonge, who is the head of public health at the School of Public Health at the University of Alabama in Birmingham. Please.
Thank you. I hope they have my slides. It's really a pleasure to be with all of you. I have a short message for you, so I know it's been a long day of conferencing. So just give me 15 minutes and we'll be out of here. But I really want you to listen to my message. My name is Kunle Alonge, and I'm originally from Nigeria. I've had the privilege of being born and raised in Nigeria, and I've also had the privilege of working as a public health physician in several African countries, and collaborated with colleagues in different parts of the world, including Asia, and I've been living in America for quite a while now. So I feel the tension. So I really do feel the tension in a very personal way. I'm being pulled to my roots in Nigeria, and I see the challenges here in North America, and those challenges are pervasive in other parts of the world. So I've been given this task of summarizing and reflecting on all that has happened over the last 3 days. And I'm not sure I've done justice to it, but what I've done is really to give us something to think about, something to consider as we go. And I've intentionally prepared slides so that way we can both see and hear some of these messages. For sure, CUGH is listening. I'm not sure there has been someone like me in the leadership of the executive committee of CUGH in a long time. So CUGH is listening. And again, you heard that the next conference in 2027 is going to be outside of the US. And there's a lot of consultation with colleagues and entities from the Global South to really do get more representation in CUGH. So a couple of reflections about how this conference has been. The conference was themed Innovating and Implementing in Global Health for a Sustainable Future. Recognizing that the challenges that we have are not challenges of discovery. They are challenges of implementing what we know, that there is a no-do gap, and that's really one of the reasons why we have persistent global public health problems. And again, thinking about it in a sustainable way, as we've heard. And that theme was threatened. In fact, the conference itself was threatened by a lot of things that happened. Leading up to this time, it was almost as if this conference was not going to happen. But I really want to say on behalf of the board, the CH board, to really appreciate the secretariat who have had to pivot and pivot and pivot. You know, for those who watch Friends, just continue to pivot to make this happen. And as well as the committees, the different CUGH committees who have been working behind the scene, from operation to education committee, and of course the executive planning committee, who have worked tirelessly to put this together. And of course, I would be remiss without not thanking the institution that have hosted us, including my own institution, that have been so magnanimous in the face of all of the things that are happening, to set aside resources to make this happen. So this is what it looks in terms of numbers. Even though we proposed to have about 230 speakers, but we're successful in spite of the odds. Against all odds, we still have about 171 speakers coming to talk to us at CUGH. We have over 1,300 participants from over 60 countries that we've heard. That's also including over 900 registrants for the satellite session. And of course, the poster sessions were fantastic. We have over 540 poster sessions representing global public health, global clinical medicine, global public health nursing, and other interdisciplinary activities that are happening in different parts of the world. So by and large, I think against all odds, this conference has really been successful, considering this number and considering the point of view that it almost could not have taken place if not for your support and your persistence, your determination to continue to forge ahead in spite of different oppositions. And this is what it looks like in pictures. So we see the plethora of peoples represented from different parts of the world and cultures. And more pictures for you, just to show the diversity, of representation, not just in color, but also in age and in class. And one of the things that have really enamored me or intrigued me in the course of this conference is really just to see the passion of young professionals, including myself, and students. And when you consider all of that, then you know that there is indeed hope even for global health. Even though it might look as if things are falling apart, but there is yet hope when you look at the deep reserve that we have in the future, particularly our young ones. Just to give some context, that this conference did not occur in a vacuum. So really, there's a lot that was happening leading up to this conference, and there's a lot that continues to happen even up to today. And I'm not talking changing U.S. government policies. Of course, that is included in my reflection. But I'm actually talking about tensions that predate many years, that predates even before some of us were born. I'm talking about things that undergird the way we live together as a society, as a collective. I'm talking about colonialism. I'm talking about people being disenfranchised to perform their civic duty. I'm talking about issues around decolonizing global health. Whose voice, who's determining the agenda for global health? Whose voice is being captured? Whose epistemology? Who is telling us how to know things? And all of those tensions have continued to pull CUGH in different directions. But just to reflect that indeed there are significant progress that have been made globally, thanks to all of your effort and to the effort of leaders that have come before us and people that have come before us on whose shoulders we are standing. And some of them are here today, But there is still yet a lot of work to be done. So despite the progress in global health, we've increased life expectancy, we've reduced inequalities to some degree. People are living longer, we are saving lives from maternal death and so on and so forth. There is still yet persistent inequities. That is to say, inequalities that are guarded by unfairness, by injustices in their various forms and shape. And we've seen a world that have grown increasingly tired of the status quo. They don't know what they want, but everybody wants a change. Right. People are demanding change of government. People are demanding change of science. I mean, what science should be, what science should tell them. People are demanding change of global health institutions like the WHO, like the UNICEF of this world. People want to see things done in more efficient ways. Again, people don't know, but there is a convergence of desire for a change, not just only in America, not just only in Nigeria, not only in India or in China, but it's a tide that is spreading all over the world. And of course, it's in those contexts that CUGH has to operate, that this conference has taken place. Of course, we've talked about the misinformation, Ms. Alexander Page really put it quite nicely. Put it out there where nobody can get a ladder to get it. And I will counter that and say that the counter is to build an alternative narrative that continues to go bigger and bigger and bigger until it surpasses the lie that is high up there on the tree. And again, as academics, we have to look into ourselves. Our academic institutions are basically structured to self-preserve. They are not necessarily structured to respond to the needs of the people. In fact, one of the reasons why we are where we are today is because we've been disconnected from the communities that we should serve. And I'm not just talking about here in America, but I'm talking about in every part of the world, whether we are in LMIC, whether we are in resource-limited setting, and so on. And again, we've seen it, minorities being erased. Again, not just only here in the US, but again, all over the world. So, what does this bring us to? And I'm a Nigerian, so I speak from Things Fall Apart, written by Chinua Achebe. Global health is definitely at an inflection point. We really are at a point where whatever we do now will determine what will happen, what will determine the course of the next generation. Some people are saying that the golden era of global health is over, and I say that it is not true. I say that we have a choice to make on what global health is going to be, even moving into the future. And one of the things that we need to recognize is that the world around us is changing. And that was really the premise of Things Fall Apart. When the falcon cannot hear the falconer, things then fall apart because anarchy is loosed upon the world. That is, when we fail to recognize whose constituent we are representing, who are the people that we should be speaking for, whose priorities we should be emphasizing, what should be our focus, then things fall apart. So we do have a choice to make. We very much have a choice to make. So again, I'm not going to belabor what I've been said, but what I try to do is to give you some themes that have emerged from this conference. And I intentionally wanted you to see it on the slide, so that as you hear me, you also see it, right? We started by saying family must come together in crisis. And these are not the time to quibble over who is involved in global health, who is not involved in global health. All of us that are aspiring to advance the health of vulnerable populations in resource-limited settings everywhere must come together. Irrespective of our class, of our creed, of our race, of the background that we come from, of our politics, of our agenda, we must all come together. And again, the question has been resolved. Should global health practitioners or it's academics, but I actually said it's not just academics, even though we focus on academics. But everybody involved in global health should be involved in politics. That has been resolved. But we've actually also clarified what kind of politics we should be involved in. We're not talking about right-wing politics or left-wing politics. We are talking about politics that stands with the truth, some truth that are self-evident, politics that stand with evidence-based practices, evidence-based solutions. That is the policy. That is to say, I work with the right if they are standing for evidence-based solution. I work with the left if they are standing for evidence-based solution. That is what determines my politics. That is where I stand. That is what I stand for. And again, we've heard about the need to communicate, the need to work in our community, to articulate more clearly what global health is, and the implication when you remove this architecture, when you remove all of this system that have been put in place, the implication for livelihood, the implication for survival, the implication for security, and that requires going back to the foundation, to the community, where we change people one person at a time. We have to be ambassadors, like my colleague from Sierra Leone did say. All of us have to be able to articulate clearly what global health is, what are the benefits of global health, not just only to communities in low and middle income country setting, but also communities here in high income country setting, to the extent that there are vulnerabilities everywhere, there are resource limitations everywhere. We need to focus on evidence-based solutions, not just on discovery, but implementing, doing what we know works for population. And that should be based on what the population is describing. So it should be responsive. And of course, we need to unleash the power of technology, AI in global health delivery. And then we need to think about the long game. That is sustainable, strategic decisions, not quick fixes, like my colleague did said earlier on at the beginning of the conference. Long commitment with partnership, standing shoulder to shoulder with people, not just helicopter partnership. Our project, I come to you, we are there with you through thick and thin. So I'm going to leave you with a call to action. I really want you to consider some of these things. And this goes to all of us, whether you're an academic, whether you're a researcher, whether you're a student, whether you're from the global north or global south, this call to action is to all of us. And there are three things that I really want you to consider. I'm not saying that this is all there is to do, but I want you to consider these three things. And I'm looking into your eye, because where I come from, they say the conversation is in the eye. It's not in the reading of the note, it's in the eye. And I'm looking to all of us to build a big tent for global health. What do I mean by that? That is, we bring everybody under that is committed to the mission of advancing health for everyone, not regarding their politics, not regarding their creed, not regarding their class. We create an enabling environment for everybody to come together. And then when we have that big tent, then we can have a big voice, right? That is, we can be the big voice for global health, in all of our communities. Educating people, educating community, reaching across the eye on what global health is and why it matters. Echoing the successes of global health, smallpox eradication, reduction in diseases, life expectancy increase. We need to continue to speak that message. I come from Alabama, and people have asked us, where is a state university investing in global health? So we need to learn how to communicate that, yes, global health involves people in Alabama as well. It's not just people in international health. All of us is global health. And we need big actions, right? And you cannot have big actions without really clarifying your intention and motives. A lot of us are into global health for different intentions and motives. But if your motive is not for the higher purpose of making a change in the world, like we saw from the quote of Jimmy Carter and Rosalind Carter, it's really for you to recognize that I can be a force to change. If that is your motive, then focus your efforts on implementing actions that the population truly needs. Respond to them. And then lastly, I have specific instructions for different groups of people here. Academics, researchers, be humble. Be humble. Embed yourself within communities. Don't sit high up there in the citadel of knowledge. You are only as relevant to the extent to which you can respond to the needs of your community. And we are seeing that happening right before our eyes now. We need to be in the communities. And then we need to seek true partnership with community members. And we need to be responsive to their needs, not our own needs for advancement, for career, but it's really to addressing the needs of the population that we represent. For my colleagues in Global North, these are trying times, but these are the times to dig in. We need to advocate. We need to do the politics now. And I've clarified the kind of politics that we are talking about. We need to advocate, we need to engage politics, and we need to explicate to our constituents that, yes, the benefits of global health is for all of us, including those in the Global North. And for our colleagues, I also represent from Nigeria, from Thailand, from India, from LMICs, power is shifting to you, whether you want it or not. We've been clamoring for a power shift to the south, power shift to the south. Now that power is actually shifting to the south. So the question is, are you going to rise up to the occasion? That is to say that resources for global health must also come from the global south. And we might think ourselves that we don't have enough, but I tell you, when we manage what we have, it can go a long way. No, I'm not just talking about money. We've heard about capacity. We've heard about great work that frontline health workers are doing in different parts of the world. We need to harness those power. And then lastly, I look to young professionals and students. I happened upon a conversation in the elevator on the first day of the conference, and an OBGYN resident was talking to another person, and she was saying, oh, they are coming for my license. And then the other person was saying, oh, I'm a global health researcher, or maybe I will not have a job in some years to come. Another colleague of mine said, oh, yeah, I'm too young to retire, but yeah, too old to change my CV. It's just a sense of despondency, but I have a call for you, that you have what it takes to face what is confronting us, and we are all looking to you. You must find a way. You must, beyond all that I've said, our generation, I speak for myself and I speak for those who are behind me, we are uniquely placed, even though we might not know it yet, but there is a calling on us even to rise up, to build on the legacy that has been built, that has been laid down for us, to raise that even to the next level. And with that, let's come together again in 2026, April 10 to 12 in Washington, D.C. What family do? Family don't just come together, family show up. So let's show up in D.C. Thank you. You could see that I'm not so used to this. So with that, I'm really going to call this conference to a close. And I really want to appreciate every one of us for our contribution, for the energy. I know it has been cathartic for a lot of us just to come here, to heal together, to bond together. Let's carry that energy back to our constituents and be the force for change. Thanks a lot.